Our first presenter today is Dr. Chelsea Walton, a clinical psychologist at the Wellness Center. Dr. Walton incorporates elements of cognitive behavioral therapy and mindfulness-based interventions in her work with clients with the aim of helping them move beyond their challenges, achieve their goals, and find joy in the present. And today she will be presenting on perinatal mental health awareness. Dr. Chelsea?
Good morning. It is my honor to be here today on the final day of the healthcare conference to present on a topic that is of personal and professional interest to myself, and that's perinatal mental health. And so maybe this is a topic that you have heard kind of gain more conversation in recent times. If not, that's okay. The purpose of this presentation is to share some information on this topic, and hopefully leaving here you will have a better understanding of what this is and what we can do to support the population. Oh, pointing the wrong way. Okay. All right. And so perinatal mental health, what is it? That's something that we'll be defining in this presentation, as well as some of the difficulties that may present in pregnant women or women in the postpartum period. Dads also included, but we'll be talking a bit more about kind of mood and anxiety disorders, what that looks like, why it's important for us to be able to identify and address these mental health concerns, as well as what are some of the benefits of addressing these difficulties and supporting this population, and what are some of the things that are associated with unmanaged mental illness in parents? I keep forgetting that, sorry. Okay. All right, so what is perinatal mental health? So that just refers to a woman's state of mental and emotional well-being during pregnancy and the postpartum period. And this definition can also include dads as well, as they also, as you'll learn throughout this presentation, can struggle with mental illness as it relates to the transition to parenthood. And perinatal refers to the period from kind of conception through the couple of years following childbirth. And so there's some kind of debate about how long the postpartum period is, but when we're talking about perinatal mental health, because depressive symptoms can persist beyond kind of a year post-childbirth, the period is kind of extended. So that we can continue to kind of track and monitor symptom progression during that time and ensure that parents receive kind of the support that they need in those early years. Okay, and so although this isn't a topic that is maybe widely discussed, maybe we've noticed that, over recent years, there's been more discussion about mental health issues. People are talking about it more openly. There's a lot more advocacy, research, and focus on kind of treatment, reducing stigma. This is an area that is kind of is not well researched, or there's not a significant kind of focus on in general, but it's important to kind of include this within the broader conversation about mental health, because either through our experiences as a healthcare provider, we're likely working with someone who has the potential to be impacted by perinatal mental illness, or in our personal lives, if we have ever given birth, if we know someone that's given birth, we're born, we're here, right? It's relevant, both personally, definitely, and professionally, it's very likely that it is as well. Okay, and so it was first kind of referenced by Hippocrates way back when, who, I mean, just the father of medicine, noticing that, there were changes in the mood of women, particularly in the postpartum period, and then maybe we didn't really hear too much about it again for the next millennium and a half, but a French psychiatrist, Louis Marseille, published the first paper on perinatal mental illness or postpartum mental illness. And so kind of after that point, a lot more discussion, awareness, research, and focus on treatment has begun to evolve, especially in the past few decades. And then through the 1900s as well, the Marseille Society was founded, which their goal was really to focus on those things that I previously mentioned: research, treatment, and providing support for those in the perinatal period. Okay, and so something that has kind of helped to solidify perinatal mental illness as, a condition that is worth researching, understanding, talking about, and focusing on treatment is its inclusion in the DSM-4. So that's the Diagnostic and Statistical Manual of Mental Disorders, and that is a diagnostic tool that's used by mental health professionals in diagnosing mental health concerns or mental disorders, psychiatric illness. And so with that being added to the DSM, that's really helped to kind of just highlight that this is an area that is worth exploring further. And with that, we can develop ways of better kind of conceptualizing difficulties that may occur in this population in terms of mental health, as well as provide treatment. And so kind of in today's age and in recent years, there's been a lot more discussion, especially on social media, about some of the challenges that parents face, mothers in particular, during pregnancy, their experiences, the transition to motherhood, so matrescence, as well as some of the mental health challenges that fathers face. Those are things that are kind of entering kind of the consciousness a bit more over recent years, and now there are a lot of providers that are certified in perinatal mental health. There's more resources available. There are virtual support groups that are available online, and this presentation, really the aim of that is to help kind of further that discussion. And so when we're talking about perinatal mental illness, there's a term that kind of just helps to kind of encapsulate the different psychiatric disorders that we might see in this population. So that's PMADs, perinatal mood and anxiety disorders, and that encompasses depression, anxiety, bipolar disorder, psychosis, as well as postpartum post-traumatic stress. And we'll talk a bit more in depth about what these disorders can look like and how these present in a perinatal population. Okay, and so why is this even kind of worth talking about? How prevalent of an issue is this? So before COVID, the CDC estimated that 1 out of 8 women in the US experienced postpartum depression. And so that's a significant number of women that are experiencing this. And in the early stages of COVID, that number increased to 1 out of 3 women being screened positive for postpartum depression. And that was attributed to a lot of the stresses that we faced throughout COVID, such as social distancing, threats to our health, the health of our loved ones, our families, restrictions on travel. It really disrupted the social support aspect that a lot of new mothers could expect to get or would kind of hope or anticipate to get during that time, right? So having family be able to travel and come visit mom and baby, maybe even leading up to childbirth, right? There, with restrictions in the hospitals and social distancing, then maybe partners and other social supports weren't able to attend a prenatal appointment. There's the worry about who's going to be able to be there during delivery as well, hoping that person didn't have COVID at that time. And so there was a lot of stress during that period, and it did really make this population quite vulnerable to experiencing perinatal depression, postpartum depression specifically. And throughout this presentation, I'll kind of mostly refer to the mom and maternal mental health, just because moms are most directly impacted by pregnancy and childbirth and physiological changes postpartum, but I think that it's also important to recognize that fathers can also struggle with their mental health as it relates to their transition to parenthood, to fatherhood. So 1 out of 10 men in the US were estimated to struggle with paternal depression, and the strongest predictor of that was depression in the mother, even beyond the father's previous history of depression or any kind of psychiatric illness. And so something else to kind of consider as well is because a lot of this data isn't coming out of our community necessarily, it's coming out of the US and other areas, but that this is actually a global experience. Rates are pretty similar across the globe, even though they're a bit higher in the Western world. But this is something that does not discriminate. It can impact anyone who is part of a childbearing family, and there are obviously risk factors that will increase the likelihood that someone will develop a psychiatric disorder in this perinatal period, but overall just being kind of mindful that this is within our community as well. Okay, and so there are some concerns, even with seeing that there is a significant number of mothers who have been estimated to have perinatal depression, that that there is underreporting of these symptoms, and a lot of that kind of comes down to stigma. So it can be really difficult for parents, new parents, to kind of move beyond the expectations that they may have of themselves, that society kind of imposes, the messaging that, pregnancy is supposed to be a joyous time, you should feel nothing but bliss, you have that pregnancy glow, you should, as soon as you meet your baby, you're gonna fall deeply in love, and everything is gonna be amazing, you'll be great, you'll just, experience unadulterated bliss and joy. And so those expectations can prevent mothers from kind of opening up about things that they're experiencing that, are distressing, that are impacting how they're functioning, that their mental health might be deteriorating. And then the other side of that in terms of, why rates might be variable, or maybe we're not kind of capturing everyone who might be impacted by postpartum depression, is that there's concerns about it being under-identified. And so per the American Academy of Pediatrics, a survey done in 2013, and it was replicated again in 2019, indicated that less than half of pediatricians screened for postpartum depression. And you might be thinking, well, their role is not necessarily to kind of take care of the mom. Their role is to kind of focus in on the baby. But in the postpartum period, usually one of the healthcare providers that has the most frequent contact with mom is a pediatrician. And so this is a really good opportunity for these symptoms of postpartum depression to be identified and for some assessment to be incorporated in those appointments, right? And so, kind of keep forgetting that. All right, and so something else to kind of consider as well is that the prevalence of perinatal depression in women with low income pretty much doubles. And so that's a risk factor, and that's a statistic that is quite alarming and significant, and something to kind of keep in mind if you are working with this population, that there is a likelihood that this is, that they're at greater risk. Okay, so kind of moving along into what is depression, anxiety, what this looks like, and what this looks like in this population. And so it can be helpful to have a bit of an understanding of kind of what are some of the signs and symptoms of depression. So major depressive disorder is characterized by having low mood, a depressed mood for most of the day, more often than not. And there are a lot of physiological symptoms that are associated with depression, such as, fatigue, feeling lethargic, disturbances in sleep, so maybe oversleeping or having difficulty with sleeping, insomnia, as well as appetite disturbance, maybe overeating or not having an appetite that leads to unintentional weight loss or gain. There are also the emotional aspects as well, such as feelings of, excessive guilt, feelings of hopelessness, worthlessness, thinking that things will kind of never change, never improve, that they'll be stuck in their circumstances, as well as some, either thoughts about death or dying or harming oneself. Those can be a picture of depression. And so it doesn't always show up in maybe the ways that we stereotypically think. A lot of individuals are able to kind of mask their depression, right? Kind of everything looks good on paper, but we don't know what this person is kind of dealing with internally. And so that's where kind of being open to kind of having these conversations is helpful in kind of identifying the well-being of a new mom, or, well, kind of anyone in general, because we all have mental health, right? But for the purposes of this presentation, moms and new dads. And so in how depression may show up in this population is that it might look like, a mom that's very overwhelmed, is very frazzled, very stressed, kind of zoned out, touched out, may struggle with caring for themselves, struggle with caring for their families, may not respond to things that they usually enjoy or find pleasure in, whether that's activities or connection with others. They might be a bit more isolated or kind of withdrawn. There can be an increased reporting of those somatic symptoms that we discussed in the previous slide, like some of those GI problems, aches, pains, that might be a part of the presentation. But sentiments such as kind of like, I don't feel like myself, this isn't like me, this is not really what I thought motherhood would be like or fatherhood would be like. I don't really feel that connection to baby. Those are all signs that a new mom might be struggling with postpartum depression. And so those are things to kind of look out for in working with this population. Okay, and then some of the things that were described as being part of depression, like sleep disturbance, appetite disturbance, it can be a bit difficult to kind of differentiate, why is this occurring? How is this different than what, moms, pregnant moms, new moms experience, right? Because, we are aware that there are a lot of physical changes that occur that can lead to pregnant moms experiencing some of these things. And so the ways that they differ is that, with pregnant moms, when there's sleep disturbance, usually due to kind of physical discomfort. So, difficulty kind of with getting comfortable, with sleeping, like their sleep not being disturbed because of, heartburn, needing to frequently get up to use the bathroom throughout the night. They may also, appear to be quite emotionally reactive and tearful, may cry at things like commercials, right? But mood is generally a bit more positive and labile. So there are fluctuations in the mood. It's not kind of a low, depressed, gloomy, or irritable kind of presentation that you'll be seeing. Appetite will tend to increase across the course of the pregnancy as there are increased demands on mom for energy. Mom is, does have some joy and anticipation, even if that is mixed in with worry. And suicidal ideation isn't a part of the typical pregnancy, right? And so in terms of depression, it looks like a lot more kind of like what we described in the previous slide, right? So there might be kind of more of a gloomy mood, gloomy kind of presentation, or maybe it shows up as being irritable or angry, or I don't know if you've heard the term kind of mom rage, right? Those are kind of more along the lines of what can be experienced emotionally. There may also be kind of low self-esteem or guilt present, difficulty with sleep, but not for the regular reasons such as, the heartburn or needing to use the bathroom throughout the night. Mom may be fatigued, but, even with kind of rest, the energy level doesn't really quite restore. So, that might kind of sound like, yes, I'm getting a lot of sleep, but yeah, I'm not really feeling like it's restorative. I still don't really feel rested. And a difficulty with kind of experiencing pleasure in response to engagement with activities that, they usually like or enjoy, or connecting with others who are important to them. And appetite tends to be dysregulated, and not for underlying medical reasons such as, extreme nausea or vomiting that can occur during pregnancy. Okay, and so to kind of further tease apart another experience that is typical in the postpartum period, but may look like depression, but isn't. It's not mild depression, it's the baby blues, and that's a period of tearfulness, emotional reactivity, exhaustion following childbirth, and it tends to last between 2 days to 2 weeks. And so after 2 weeks, you wouldn't really expect to kind of see that these signs persist. The baby blues kind of burn out after that period of time, and it's caused by hormone fluctuation at the time of birth and acute sleep deprivation. But generally, mom is happy, mom is content, and responds well to when she has opportunities to rest or engage with, her social connections, family, friends, whoever. And so just something to be mindful of. In the next couple of slides, we'll talk about postpartum PTSD, and so we'll reference birth trauma. And though I won't get into any specific details or really get into kind of describing situations that it can occur, it might be something that you just want to be mindful of in terms of taking care of yourself. There it is. And so as healthcare providers, and just as members of a community and family members, friends, it's really important to recognize that we don't get to say what is traumatic for someone else. And this quote helps to kind of encapsulate that. It says that birth trauma lies in the eyes of the beholder. And so a lot of times mothers who perceived their births as being traumatic, those same experiences or events were perceived as being kind of routine by their providers. And so it's important to be kind of mindful of that with working with this population as well. Right? And birth trauma, just really kind of refers to any event that occurs that during the labor or during the birth process that can involve actual or threatened injury or death to either the mother or her infant, or the woman feeling as though she's stripped of her dignity or there's a loss of autonomy. And so approximately 9% of women experience postpartum PTSD symptoms. So that might not mean that they meet full criteria for PTSD, but they're experiencing that post-traumatic stress. And so there is that, that experiencing of symptoms that is, difficult and indicates that, something during that process may have been traumatic for the mother. Women who have experienced previous trauma are at higher risk for developing postpartum PTSD. And so, in terms of kind of prenatal appointments and prenatal care and the process of birth, that some of those things that need to occur can be quite re-traumatizing for someone who may have experienced a previous trauma. And so it's just important to kind of keep that in mind when working with this population. And these are some of the examples of experiences that may be deemed traumatic in this population. And so some of these things, are pretty routine, pretty common. We hear about them occurring quite frequently, but just because we may have been desensitized to some of these things, or we think they're common, that doesn't mean that they're not stressful and difficult for mom to process and deal with. And so your thought is like, okay, well, you made it through, you're fine medically, everything is good. Maybe we have the data on, what the risk is, but going through the actual event can be quite stressful, and it may take some time kind of emotionally and mentally to kind of recover from some of these events. And that also includes kind of feeling powerless or feeling, as though they didn't have the support that they needed throughout the process of childbearing, or got the reassurance that they needed during delivery. So some of the things that can contribute to a woman experiencing birth trauma and post-traumatic stress symptoms are not necessarily any kind of medical procedure, but kind of speak more to kind of the communication and the support that is provided throughout the birth process. And so postpartum PTSD symptoms, what can this look like in this population? So PTSD includes intrusive re-experiencing of the past traumatic event. So that can either be the childbirth itself, or it can be a previous trauma that is being re-experienced. They've been re-traumatized throughout the process of pregnancy, labor, delivery. And so that might look like having images or thoughts about the trauma that are unwanted, that are distressing. It also can look like having flashbacks or nightmares, feeling as though they're kind of reliving it mentally, or again, having that show up as very vivid, difficult dreams about the event. Avoidance of stimuli associated with the event, so that could include, certain places or people that may remind the parent of what occurred that was traumatic to them. And so this can kind of look like, maybe you have a mom who, had an emergency C-section. Maybe her obstetrician was present for that. This is something that was traumatic for her. This is not how she expected that, her birth would go. The process of recovery has been quite difficult and challenging, and she's experiencing kind of negative thoughts about the event, an increased sense of kind of arousal, just feeling on edge, finding it difficult to kind of relax, anxiety, panic, and kind of feeling like, I can't believe this happened to me, like it's kind of surreal, like don't necessarily feel kind of connected with that experience, or I felt like, you know, when this was going on, I was kind of outside of my body watching it happen, right? And so avoidance can occur because when there's, you know, any kind of reminder about that event, the body is kind of remembering the stress of the situation, and really want to kind of, there's a drive to kind of reduce that distress. And so it might look like, you know, needing to have certain follow-up procedures or having follow-up appointments and avoiding that, because it is just too stressful to kind of engage with that doctor, or when engaging with that doctor, you know, that parent, that mom might feel like, you know, she's reliving that whole experience again. Okay, I'm convinced it's just me now. I'm clicking in the right direction. It's personal. Okay. Okay. Oh no. Okay, here we go. Okay, and so kind of moving on to perinatal anxiety, because this is another very prevalent psychiatric illness that can occur in this population, and it really looks like having excessive worry that is difficult to control. There's a lot of physiological symptoms, so that stress response is activated. So we can, when dealing with anxiety, experience, you know, rapid heartbeat, rapid breathing, feeling tense, kind of on edge, difficult to kind of wind down, difficult to kind of relax. May feel as well as though, you know, thoughts are kind of racing, our mind is going blank, it's hard to focus, just because once that stress response is activated, the area that we kind of credit for doing a lot of our thinking kind of goes offline. And so this in a new mom may look like, you know, or even in a mom and dad who are, you know, they're expecting, may look like, you know, oh, I think that, you know, something is wrong with my baby despite being perfectly healthy. They're following, you know, all of the doctor's recommendations. The scans show that everything is going well with baby, and so kind of despite reassurance and despite evidence that suggests that, you know, baby is fine, the pregnancy is going well, there's nothing to worry about at this time, they have difficulty with kind of controlling those worries, and experience these symptoms as a result of that, right? And so something that's interesting to note is that prenatal anxiety rates are fairly similar in moms and dads, and so dads also can be kind of plagued with this worry and this anxiety, and that might be for different reasons. Yeah, there might be thoughts about, oh my goodness, like, you know, what's going to happen with the baby? Is the baby okay? You know, what's going to happen during childbirth? You know, is something going to happen? Am I going to lose my, you know, my partner and my child? Or it may be about, you know, am I going to be a good dad? Is my baby going to recognize me? Are they going to love me? They're just going to love mom? Can I provide for my family? So the sources of worry may be a bit different, but the experience is kind of occurring at similar rates. And so kind of moving into postpartum OCD. So prevalence rates for this disorder in perinatal population or postpartum population are a bit more variable due to kind of limited research, but estimates are between kind of 1.7% to 7%. And a part of that is that just the kind of the nature of OCD, so the intrusive thoughts that are distressing, that are alarming, this might not be something that a new parent will readily disclose. And so that's a part of why, you know, this might be something that is difficult to kind of identify and difficult to kind of establish some, I guess, more solid statistical data on, or research on, because a lot of times with the thoughts that can occur as part of OCD and postpartum, there is a concern that, you know, if they share it with someone, they're going to think that, you know, they're an awful parent, that their child may be taken from them. But the reality is that those who are suffering postpartum OCD are often at really low risk of actually doing anything to harm their baby, right? And so how this may present is, you know, a mother in the postpartum period who has these intrusive, recurring, really distressing thoughts or images about, you know, maybe rolling their baby down the stairs, right? And so that is a thought that is really distressing, just kind of thinking about it. I don't think that any of us really are happy with kind of having that thought of something happening with a baby, right? And so so a mom may have these kinds of thoughts, right, that she might do something to harm her baby, and as a way to kind of neutralize the anxiety that comes from having those kinds of thoughts, you may see that there are some compulsive behaviors or avoidance, and so that might look like, you know, mom never carrying baby on the stairs, you know, only, you know, dad and grandma are allowed to, you know, carry baby down the stairs. Or can also look like having to engage in certain rituals before, so maybe counting or, you know, repeating certain things internally in their mind before being able to kind of, you know, have that anxiety settle and, you know, be able to kind of move about, right? And so these thoughts are ego dystonic. So these are unwanted thoughts. These are thoughts that this mother does not want to have, or this father does not want to have, and it causes severe distress. And unfortunately, with OCD, the anxiety tends to kind of cling on to what is really important to that person. So again, the likelihood that there will be kind of action behind these thoughts is really, really low. And instead, this is a mom that kind of needs that support and needs to kind of recognize what is happening through, you know, referral to an appropriate source, or just, you know, having it validated that, you know, the thoughts are really distressing, but it doesn't sound like this is something that, you know, she is wanting to do, but she does need some support to kind of work through it to be able to have some relief and to be able to function. And so common presentations will include harm coming to baby, either deliberately or by accident, or contamination, worry about, you know, excessive worry about kind of germs, that might result in excessive cleaning, organizing, rearranging, or other rituals. Okay, and so postpartum OCD can really lead to moms being caught in a spiral of what ifs. Perinatal women are at a significantly increased likelihood of developing OCD than the general population. And again, they find these symptoms to be severely distressing, and depression also tends to be a part of the picture. And so, again, just to kind of illustrate that, you know, you might not necessarily be able to kind of gauge how, you know, a new mom is doing just by kind of asking, or, you know, making a statement that is, I guess, kind of presumptive that this is, you know, the best time of her life, everything is going well. There can be a lot kind of going on internally, and this is just a little illustration that I like that helps to, you know, highlight that. Okay, and so in terms of some of the risk factors for PMADs, things that will increase the likelihood that a mother will develop a mood or anxiety disorder during pregnancy or in the postpartum period include having a family history of PMADs, and so having that genetic predisposition to this experience, as well as a personal previous history. So, already having pre-existing anxiety or depression, or, as mentioned in previous slides, trauma puts new parents at risk of developing a mood and anxiety disorder in this period, as well as history of child abuse that kind of falls in under kind of the trauma, adverse childhood experiences, so really challenging adversities that children may experience kind of in the early developmental phase, put them at risk for experiencing mental health difficulties across the lifespan, just kind of in more general sense in terms of the population, but the transition to parenthood, pregnancy, postpartum, all of the changes, hormonal fluctuations, that all kind of amplifies that risk. The number of children as well. So children can be very demanding, and so as the number of children in the family increase, the mother also is at increased likelihood for developing a postpartum mental illness. Education level as well, so lower education level is associated with increased likelihood of developing a perinatal mental illness, and that's kind of for the reasons that with higher education we tend to see that there may be more income, there's more access to resources, there's less barriers to care, and so not having access to the support that is a really fundamental part of the well-being of childbearing families puts them at a significant risk. Some of the social risk factors for perinatal mental illness include inadequate partner or social support, and so social support is, as previously mentioned, is a really important part of the well-being of new moms, new dads, right? People always talk about it takes a village. Some people will transition to parenthood and they're looking around like, well, where is the village, right? They need that support to kind of step in and provide breaks, give them an opportunity to take care of themselves, to be able to kind of rest, to be able to reestablish, engagement with things that, bring them pleasure and joy, as well as having that connectedness with others is a major buffer for stress. And if you were here for some of the presentations yesterday afternoon, that was something that was emphasized, that social connectedness, social support is a major buffer for stress. And stress is something that is a risk factor for developing a mental health disorder, and one in the perinatal period. Recent loss or grief, that's another factor as well. And so kind of with moving through milestones in life and giving birth is a significant one. Transitioning to being a parent is a significant one. That can stir up grief. Grief can kind of surface during that period of time, right? And so for a mom who's transitioning to parenthood, that may have lost her mom, or is estranged from her mom, right? The grief of not having the presence of that person, that support, maybe the experience that they were expecting can be something that is dredged up during this time and increases the risk of developing perinatal mental illness. as well as kind of barriers to care or discrimination. That is another risk factor as well. And so we can see that maybe more in terms of looking at groups that may be a bit more stigmatized, such as teen parents, adolescent parents, so them not necessarily being heard or validated in the way that, a more mature woman who is married and has, life in order, may not be validated in that same way, right? And so it's kind of important, especially as a healthcare provider, to be aware of kind of biases that you have and the stigmas that exist, and to be able to support those who are, a bit more marginalized within this community. And so for partners, some of the risk factors that increase the likelihood that, perinatal mental illness, anxiety, or depression can occur would be maternal depression. And so that was one that was previously mentioned, that maternal depression was the greatest predictor for paternal depression. Feeling burdened or trapped, having the additional kind of financial responsibility, maybe there are financial constraints, financial stress, having the societal message that, dad, the man in the relationship, is a provider, that can be a trigger for anxiety in new dads. Or dads who are, going through the process of, adding another child to their family. Also kind of being outside of the circle of attention, right? And so during pregnancy, a lot of the attention is on mom and the baby and the growing belly, and dad is kind of on the margins of that. And then but there's still an ability to kind of maintain that connection, at least between mom and dad in the relationship. But then, once baby is born, then attention generally tends to shift onto baby. And people are kind of like, okay, mom, I'm here to see the baby, right? And dad, again, continues to fall in kind of those outer bands of that circle of attention. And so that's difficult as well, and so because then dad doesn't necessarily receive the support that he may need during that time, and is also struggling with feeling disconnected or deprioritized by their partner, who now has to shift their attention to focusing on their recovery, as well as meeting the demands of a newborn. As well as sleep deprivation, that's a significant factor as well, that can exacerbate the risk of perinatal mental illness occurring, and again, kind of missing the more intimate aspects of the relationship, right? That can be something that can be deprioritized once baby is born. Okay, and so if there is, signs or symptoms of a perinatal mental illness, anxiety, depression that is present, some of the factors that can amplify those symptoms would include the sleep deprivation, physical pain, so thinking about kind of moms in those early weeks, right, having to recover physically as well as dealing with the sleep deprivation, unresolved grief or loss, estrangement from their own parents, or complications that have kind of occurred during the childbearing process. Health conditions in parents or babies, so, situations in where baby, may need additional medical attention, maybe in the NICU. That can be something that can be particularly stressful for parents and families and can increase the risk of postpartum depression and anxiety. The temperament of the baby, right? Sometimes there is a mismatch between, parents' temperament. Parents may be really laid back and chill and relaxed and kind of expect that baby will be pretty easy in that way too, or they're just going to sleep all the time. But then maybe they get a baby that is more alert and more active than they anticipated, and so that puts an extra kind of demand on parents as well to meet the needs of the baby. And then other age-related stressors as well. So previously mentioned kind of being an adolescent parent, teen parent, and then being an older parent as well. Superwoman syndrome, that's another one, kind of this idea that we have to, as women, do it all and do it all perfectly, right? We've got to be the perfect mom, we've got to have the perfect nursery, the Montessori playroom, we've got to kill it at work, we've got to be the best partner, we've got to snap back, we're going to be in our pre-baby body at 6 weeks. All of those kinds of expectations just further drive anxiety and stress. And so we'll talk about some of the things that are tackled then in psychotherapy. But in terms of the role of healthcare providers, screening, right, by anyone who meets with childbearing families, so OBGYNs, pediatricians, midwives, they have a lot of opportunity to help to assess and identify if there are some signs that are showing of depression or anxiety or some other mental illness in new mom, new dad, pregnant or expectant parents, right? And so it's the PSI, and that's the Postpartum Support International organization, who does a lot of research and advocacy and training. They recommend that moms are screened at first prenatal visit, once in the second trimester, and again in the third trimester, and then pediatricians can kind of help to get involved following kind of childbirth, where we know that those visits with the OBGYN kind of tend to taper off, by trying to screen for depression or anxiety at those well checks in the first year of baby's life. And so there are some highly researched and validated measures that can be used with this population. It's the Edinburgh Postnatal Scale and the Patient Health Questionnaire, and those are readily available online. And I've also included them in a resource list that will be accessible at the end of the presentation. And so in terms of talking about talking about mental illness, talking about mental health, trying to assess, it's really important to ask about things like, are they experiencing any thoughts that are distressing, any are scary, how they feel like they're doing, asking directly about thoughts about death or dying, and just kind of making it, opening up that dialogue, making it okay to talk about their own well-being and their own mental well-being, right, during a time where there's so much emphasis on baby and how baby's doing and progressing and developing and all of the needs being met. Checking in with parents and asking directly about their experiences and trying to then connect them with practical sources of support based on what it is that they're expressing that their concerns are, or referring over to a psychotherapist or a psychiatrist or community resources that may be available. And so, as mentioned throughout this presentation a number of times, social support is incredibly important. We've talked about how important it is in the role of mediating stress, buffering that stress, and so it's essential to ensure the mental well-being of childbearing families during the pregnancy and the postpartum period. In terms of mental health treatment, some of the kind of themes or focus points throughout psychotherapy for perinatal mental illness. So tend to surround identity change, so looking at kind of shifts in, who that individual feels as though they kind of have left behind versus who they're becoming, and helping to kind of reestablish and reconnect to themselves in the postpartum period, dealing with grief and loss that might surface throughout the childbearing process, checking in expectations versus reality. Are expectations realistic, or is it reasonable, or are they setting that individual up for failure because they're just simply highly unrealistic? And so when that parent can't meet that expectation, then they think that it is something that is intrinsically wrong with them, rather than adjusting kind of the way that they're thinking about, thinking about, what it is that they ought to be doing or others should be doing, or how things should be going. As another important aspect as well is reducing comparison. And so with social media, we have access to everyone's highlight reel. That's where we see all those beautiful nurseries, Pinterest too, and those Montessori playrooms, and all those really expensive developmental wooden toys. And just parents can kind of get into the trap of feeling like if they cannot afford, if they cannot provide that means that, they're not doing what they need to do as a parent. And so helping them to kind of focus in on what's kind of within their control and what's within their means is something that we would work on as well. We kind of address superwoman syndrome, so wanting to do it all and do it all perfectly, which we shouldn't really even have a conception of, because that is not something that really exists. Working on communication and conflict resolution, so in terms of communication, helping parents to maybe ask for what it is that they need, being able to express themselves, being able to gain more social support, as well as working on conflicting ideas or thoughts or ideologies that they may have with their partner about how parenting, what their values are in terms of parenting or how things are going, as well as focusing on increased support and referring for other support methods of connection. And so there are a number of evidence-based treatment models for perinatal mental illness. So cognitive behavioral therapy is one, which is shown to be very effective for the prevention and treatment of perinatal depression and anxiety. So that looks at, how individuals are thinking about themselves, about the way their situations, and trying to identify kind of any thoughts that are unhelpful or negative or distorted, as well as finding ways to cope with emotions and doing and engaging in the behaviors and the actions and the activities, the things that work. Interpersonal therapy, there is a perinatal modification to this therapy that's manualized to treat depression, and it's shown to be quite effective along with cognitive behavioral therapy, and this looks at addressing issues within relationships for that parent. Psychoeducational group therapy, so being connected with others who may be in a similar stage or dealing with similar experiences, and having the opportunity to kind of learn more in relation to others. And mother-infant or parent-infant therapy and education. So that's a therapy that focuses on attachment between the parent and the child. And kind of just following along with talking about attachment, so we're talking about the emotional bond between parent and child and that psychological connectedness. And so part of forming a secure attachment is to be able to be a responsive caregiver. And so when baby, signals that there is a need, parent, is able to respond to that need, and that helps the baby to develop a secure attachment and carry that attachment kind of throughout life, and that shapes the way that they see, others, how they interact in relationships, and how they see the world. And so increased attachment security is one of the benefits of managing a perinatal mental illness. Maternal mental illness is one of the main barriers to secure attachment. And so we really do want to look at focusing on, the mother's experience and managing her mental illness, because it also impacts the well-being of her child, right? And so secure attachment sets kind of the pathway for a child to develop emotionally, socially, cognitively, and that kind of starts going into the area of kind of infant mental health, which is another presentation for another health conference. But through managing perinatal mental illness, especially depression, these are some of the things that we can expect to be a result of that, right? So parents are better equipped to manage challenges that come up in parenting, form better relationships with their children, tend to have healthier children, that reduces the likelihood of, those children going on to develop behavioral disorders or mental illness in their lifetime. Parents are less likely to use harsh punishment, and it helps to kind of shift the way that parents experience their children. And so healthy children need healthy parents. That first 5 years, that is critical for brain development. By age 5, the child's brain size is about 90% of the size of an adult. And so there's a lot of work kind of going on in those really cute little heads during that time. And it's really important for us to be able to lay a good groundwork, help those children with kind of developing on track, and reduce the barrier of mental illness in the parent as one that is getting in the way between them and responsive caregiving. And so mental health really starts at conception. It starts in the mom while she's pregnant, her mental well-being, and throughout her journey through labor, delivery, in that postpartum period, that, as I kind of mentioned and touched on briefly, impacts the development of the child, that infant mental health, right? We want to build resilient children who go on to be healthy adults, and as such, it's important for us to kind of go back kind of to the root and make sure that we are supporting a population that is vulnerable, is at risk, and needs that support to, kind of basically build society, right? And so that is pretty much the presentation. Sorry, the last couple slides are a little bit rushed. I know that time is up, and I'm aware of that. Thank you very much. It was my pleasure. And
thank you very much, Doc. We now move on to another important topic as we introduce our next speaker. And this is one that often gets ignored when we think about overall health, dental health. So let us invite our next speaker, Dr. Wilbert Veit, presenting on Your Teeth Are Meant to Last a Lifetime, Prevention, Detection, Health Consequences, and Treatment Modalities. Let's give it up for him.
Let's see. I only have one laser pointer. I think it's going to be on this screen. So if you're over there, you might want to move if you want to. Yeah, so will Let's see if it goes there. Yay, okay, it works. Okay. Well, thank you for this opportunity to talk about one of my favorite subjects, and that's how to keep your teeth. I'm going to kind of keep it simple. How many dentists are here? How many physicians? Okay, so I'm going to kind of keep it simple. We're going to stick to basically the two enemies of keeping your teeth, which is tooth decay or dental caries and periodontal diseases. Let's see. Okay. Let's go back a couple of centuries. This is the 17th century and the 1600s. And this was basically the advanced dentistry of the day. The people would wait until they had pain, and then they would have the tooth extracted. This is a Dutch painter, so this is in Europe. And you could see this is what a lot of people still think this way, unbelievably. Oops, going the wrong way, sorry. Okay, another Dutch painting in the 1600s. This is what it was when you went to the dentist. Traveling dentists. Sometimes they even would extract teeth on horseback, and the reason for that is generally considered that if they caused pain, the person screamed out, the mob might go after him, and he would make a quick getaway on his horse. Okay, this is from the 18th century, 1780 or so. And this was a carving made by a French artist. And it's depicting what used to be believed was the cause of toothaches. And it was the tooth worm. Now, how did they get the idea of the tooth worm? I have my theory that the tooth was extracted and it was smashed with a hammer because of all the pain that it was causing. And they looked inside and they found this little pink thing that looked like a worm. And it was actually the pulp of the tooth, or the nerve of the tooth. So, aha, that's what was causing my toothache. I want to read you something from 3,500 years ago. The Babylonians. This is the time of Nebuchadnezzar and the Code of Hammurabi. But just listen to this. This is 3,500 years ago. After Al had created heaven, this is their creation myth, the earth had created the rivers had created the canals had created the marsh, and the marsh had created the worm. The worm went weeping before Shamash, his tears flowing before Ea. What wilt thou give me for food? What wilt thou give me for sucking? I shall give you the ripe fig and the apricot. Of what use are these to me, the ripe fig and the apricot? Lift me up among the teeth and the gums. Cause me to dwell. The blood of the tooth will I suck, and the gum will I gnaw the roots. That's 3,500 years ago. And this persisted, the toothworm idea persisted right up until the 18th century. And that was the year that Leeuwenhoek made his little single lens microscope, and Robert Hooke discovered the cells of plants. So, not that long ago. Let's see, what do we got here next? Okay, so around that time was the American Revolutionary War. You all recognize this picture. He's on the money of the U.S. And in this particular painting, all of his teeth were gone except for one, and the artist had to pack cotton into his mouth to bulk out his cheeks to get a good picture. Can you imagine that? I mean, and it's said that his chronic toothaches and abscesses really affected the process of the American Revolutionary War, because he had to postpone battles and attacks and everything. Anyway, he lost all his teeth except for one. Here he is as a little younger guy, George Washington, and there's a scar on his cheek, which is probably due to an abscess, dental abscess. This is his last set of dentures. Can you imagine having something like that in your mouth? Oh my gosh. The upper part is a swaged plate of gold, and there were, they often would use human teeth welded onto it, or ivory carvings. And it's believed that he even purchased teeth from some of his slaves to have them made into his dental prostheses. So that's, how many years ago was that? 250 years ago? Okay, so the first big enemy of keeping your teeth is tooth decay. How do we detect it? Well, okay, the most obvious, the first way is by visual examination, visually looking at it. So these teeth here, if you look at these three teeth, okay, so this one looks pretty good. This is a premolar. And if you look in the grooves of this molar, you'll see some dark coloration, and you could say, well, there's probably decay there. And on the one behind it, you'll see it looks like decay in the grooves of that tooth, and you'll see some decay where the tooth has broken out here. Now, the second way is with a radiograph or an X-ray. If we take these same teeth and where'd it go? Oh no. There you go. Okay, these are the same teeth. The premolar, which looked really fine, now this is reversed because with the photo we're looking into a mirror. Okay, so you couldn't see this decay here, which is this dark area where this decay is forming in between the teeth. And on this molar, you'll see even a larger one. And that one, when we looked visually, we'd only see the decay in the grooves of the chewing surface. And look at this one. And right here is the pulp of the tooth, or the famous nerve of the tooth. And this is what brought the patient into the office because they were feeling pain. So, how in the world does this happen? Okay, well, we know what it is. It's not the tooth worm, but I'm going to show you the tooth worm later, the tooth worms. It's bacteria which produce acid from sugar. So they metabolize the sugar in your Coca-Cola or your Pepsi or your donut or your chewing gum or your mint or whatever it is, and they produce acid for about up to 20 minutes. The acid dissolves the mineral structure of the tooth and allows the bacterial colony to invade into the tooth. So it's like, like a mining procedure. They're dissolving their way into the tooth. The thing is, it's the frequency of exposure that we know is one of the most important things if you want to prevent decay. The more frequently it's going on your teeth, whether it's from a beverage or a snack or whatever, people snacking on candy bars, whatever it is, you could figure, well, the bacteria are going to absorb that sugar and produce acid for up to 20 minutes with every exposure. So the less frequently that it's getting on the teeth, the more you have the ability to prevent further decay. Now, as dentists, what we do, we try to catch these cavities when they're much, much smaller, obviously. And, but I'm going to show you what can be done in a little bit. Okay. Whoops. I'm going the wrong way, sorry. Okay, so this is a much bigger cavity, which is really obvious. We can identify this with visual. And you'll see how the bacteria have invaded in here. They dissolved away the hard structure of the tooth, and the walls of the tooth the strength is compromised. They're thinned out. And so what do you do with a tooth like this? Well, in the old days, it would be extracted. Sometimes it is extracted today. It depends on many different factors. But let's see. Oops. Okay, so here's the tooth with the decay removed. It had the nerve removed from the tooth. And you'll see that the walls of the tooth are shortened so that when we do the big bonded filling, we can cover the wall so the tooth doesn't split apart down the middle. And we also use some tiny little titanium screws that go into the tooth for additional retention. So the lesson here is don't give up. Even if it's a big cavity, the tooth can be preserved and saved. Rather than extraction and then having to deal with that. And here's what it looked like after restoring it with bonded composite filling material. So the walls are covered. This is protecting it from fracture. Ultimately, this would be recommended to eventually do a crown or a cap on the tooth to hold everything together from the outside. Okay, here's another example of a disaster. This was a big tooth-colored filling in this tooth. The outer wall fractured off. It was just hanging by the gums. And this tooth also had decay in between the teeth. What can we do with this? Okay, so rather than extracting the tooth, and by the way, there are cases where you should not extract a tooth if there's certain medical conditions, such as bisphosphonate medication, where if you do it, the osteoclasts basically, because the bone, the alveolar bone, which I'll get to later, is constantly remodeling itself. You have osteoblasts creating more bone, you have osteoclasts dissolving away the bone, so your bone is in a constant state of being replaced. And with bisphosphonates, sometimes the osteoclasts are inactivated and the bone doesn't heal properly, and you can get osteonecrosis of the bone, drug-induced, if we were to extract the tooth, if that were this person. Okay, so here it is, restored using filling material. Now here again, because it's a giant filling, we would recommend a crown on the tooth to hold it together better, but the tooth was saved. These are pictures of some crowns. You see, this is the typical crown of many, many decades. This is porcelain fused to metal. And it's kind of like the shape of a sewing thimble that you'd put over your finger. It holds the tooth together from the outside and it's bonded onto the tooth. Today, most of these crowns, we're using zirconia porcelain. It's an all porcelain crown. And this is a little bridge with crowns holding a replacement tooth. And of course, they can be made in all different shades to match the person's teeth. Okay, so this is the other demon. This is the other problem with saving teeth and keeping them for a lifetime. This is an illustration of some periodontal disease. This is, of course, gum disease. When you look at this, you'll see that the gums are coming off the roots of the teeth. You'll see the gum tissue. We have two aspects. This is the gum tissue, which is firmly attached to the bone. It's called the attached gingiva. And then below that, you have the mucosa, which is not attached to the bone. It's flexible. What the heck is causing this? Well, it's bacteria. The bacteria are making a coating on the teeth, on the roots, and inciting the inflammatory process. The gums are becoming inflamed from the bacteria. And this is causing the gums to come off the roots. It's almost as if the body was rejecting the teeth because of their bacterial coating. And in this particular case, the gums are coming off and they're receding, and the roots are becoming uncovered. You'll also see some hard, crusty material forming here. This is where the bacterial biofilm becomes calcified by the minerals in the saliva. The bacteria that are causing this destruction are not only producing toxins, but there's also a localized allergic response of the tissue to these bacteria. So it's a combination of toxins and the localized response. The hallmarks of inflammation in the gums is swelling, so these are swollen up. They can become very tender, although most of the time people that have this disease don't feel any pain, which is unfortunate because they don't come in and get treated, but there's no pain often. And so the inflammation, the inflammatory process, these cells are producing enzymes which cause destruction of the soft tissue, the attachment. These enzymes, proteases, dissolve the protein, and different enzymes. It causes the tooth basically to become rejected. Now, okay, this is an example with of mostly gingivitis here. This is where the gums themselves are inflamed, but there's not that much destruction of the bone. But what we will see here is that when we measure the gums, we can tell how much of the gum has come off of the root. If it comes off more than, say, 3 millimeters, we call it a pocket. And what's the bad thing about pockets is that, well, if the gums are coming off and there's a space between the root and the tooth, you can't really clean it. You can't brush it. And the other thing about it is that there's a transition over into what we call anaerobic bacteria, and these are more damaging to the tissues. The anaerobes like to live down in the pocket where there's no oxygen. Okay, so this is how we measure. This is a periodontal probe, and it's marked here in 3 millimeter increments. And you could see here there's some gum recession. The root is from here where the enamel stops all the way down to here. Now, if the gum had not receded, you would have a 3, 6, 9, 10 millimeter pocket between the gum and the root. The body's defense mechanisms here, are overwhelmed. There's, of course, vitamin D is one of the activators of certain peptides called defensins and cathelicidins, which actually are produced, and they attach themselves onto the bacteria, penetrate through the cell wall of the bacteria, and destroy the bacteria. They're also effective against viruses. I'm told, I don't know what the mechanism is. But of course, then you have the white blood cells, the macrophages, and all that. But it's the body's defenses is resulting in the destruction of the what's holding the teeth in the mouth. Uh-oh. Oh, here we go. Okay. So this is a radiograph or an X-ray. I think my battery's going low. Showing the bone loss that's occurring along this root. Now you could see, let's see what this. You could see how the bone has come down. From up at the top of the tooth, you'll see where it's lighter. That's the crown of the tooth, where the enamel is. But from there down is the root of the tooth. And you have a horizontal bone loss. The bone is going down. It's also vertical bone loss right along the root. So this would be deep pockets, where you have pathogenic bacteria, mostly anaerobes, living in there and causing further destruction. Okay, here's another example of some front teeth where extreme bone loss has occurred. Sorry, do you have another pointer? This? Yep. Oh, let's see, how does this one work? What do you push? This one for pointer? Oh, for pointer. Ah, okay. Oh, thank you. Beautiful. Okay. So this tooth here, you see it had root canal treatment. The nerve had to be removed from the tooth. This is the root canal filling. The bone loss is occurring around these roots. So from here all the way up, this is bone loss. And these teeth, typically, as they get loose, they'll start to wiggle, and the person becomes aware there's something going on here. Now, the tooth worm is active here. How do we treat this? Well, we treat it with different methods. Let me see. Let's see if I have to use this one to progress it. All right, this is another one on some back teeth. You see the bone loss that's occurring around the roots of these teeth. This is the maxillary sinus here. This is your sinus. So the roots of this molar are right up into the floor of the sinus. We're getting extreme bone loss. This is pretty much hopelessly involved here. Okay, well, how do we treat this? Well, there's dental floss. Of course, with dental floss, you can't get down into pockets. And many people find it too complicated to wrap the string around their fingers and get it between the teeth, clean the teeth with an up and down movement. That's pretty much has been the gold standard for many, many years. Okay, these are some devices. If you can't use dental floss, okay, you have dental floss holders. They sell them in all the supermarkets and pharmacies. This is good for between the front teeth. This is good for between the back teeth. And remember, with floss, you want to use an up and down scraping motion. It's not a sawing motion, which many people do incorrectly. So it's up and down to scrape the biofilm off the surface of the roots. These little brushes also are very helpful for many people. They come in different sizes, different diameters. This is good for in between the front teeth to remove the biofilm. Some of them can be bent at a right angle. This one is more for back teeth. And if you have bigger gaps, you can use this type of an interproximal brush to clean in between the teeth. The whole idea is to remove the bacteria, to prevent decay, the acid-producing bacteria that produce decay, and to prevent and to control periodontal disease. Okay, so if you have bridge work where crowns are connected together and you want to get your floss underneath, these are called floss threaders, and it's like a flexible sewing needle. You put your floss through the loop, you thread this underneath the bridge, and then you can go back and forth underneath the bridge to clean the undersurface of the non-removable bridge. Floss threaders. Okay, the water pick, this is a good gadget also because you can flush water between your teeth. It flushes out food particles. It also will rinse out some of the bacteria. And we also can add some antibacterial solution into the water to actually flow into pockets. So to get antiseptics, antibacterials into pockets, either squirting with a syringe or using a water pick can be very helpful. Okay, so we're looking a little more closely now. Most of us today are using these magnification loops. Not only can we see much more, but also it really helps on our, our lower back if we're always getting down close and trying to get in there. So this is a very, very helpful thing for dentists today. Now, here's some, this is a little Gary Larson humor. Early microbiologists. Looking very close, very closely. I like this guy over here. I mean, he's really looking there. Okay, here's our face contrast microscope, along with a video camera and a screen. Here's what we see. Another Gary Larson. Okay, husband and wife, they're arguing over his activities. And he says, I have news for you, sweetheart. I really am the lowest form of life on earth. Gary Larson. Okay, here we are. This is looking in. Now, let's see if we can activate that. Okay, so we're looking at the screen. So here you have a trichomonad in somebody's biofilm that we took from a deep pocket. And you'll see bacteria, the modal types of bacteria are spirochetes and modal rods with flagellum. This indicates risk factors for the periodontal disease. Paul Keyes, back in the 1960s, came up with the idea. There was a big debate among periodontists, which are the specialists in treating periodontal disease. And they believed, and I remember the lectures very well back in the 70s, well, we don't really know what causes pockets. But once the pocket forms, the bacteria go in there and they live in the pocket. And so one of the main treatment was to surgically remove the pockets by repositioning the gums. Paul Keyes said, no, let's apply the Koch postulates, and we know that if you have certain bacteria and it causes disease, well, that's the cause of the disease, and what we really need to focus on is the bacteria. And the periodontists would debate, no, we don't want to use antiseptics, we seldom use antibiotics, because what we're really focusing on is the calculus. That's the hard, crusty material that builds up. It's been proven that it's not the calculus that causes the destruction, because they've done experiments where they've sterilized calculus and they've implanted it and it didn't cause any inflammation. The problem with calculus is it's a good place for bacteria to live because of its porosities. So bacteria will, bacteria often, especially the spirochetes, will live on the calculus. So it needs to be removed in the treatment of the periodontal condition. Okay, this is another one. It's a little bit darker. On this one, sorry, with the big magnification on the screen, it's a little fuzzy, but this is a little more active sample showing spirochetes, Treponema denticola. Now, there are other bacteria that like to live in deep pockets where there's no oxygen, that are not mobile, they don't move around. But by doing these bacterial tests, Dr. Kai's, his question was, well, how do you know when it's in remission? How do you know when the disease is in remission and you can, stop or slow down the treatment? And the only way to really do it with a very sensitive microbiological test is to take samples, because just like you have testing in swimming pools for E. coli, and when you do your samples to see other infections are in remission, once this is treated, even just non-surgically, what we've found is that there'll be no more spirochetes, there'll be no more motile rods, the large numbers of white blood cells that were in the pocket disappear, and there's nothing moving. And that would be considered that it's in remission. Unfortunately, this method of monitoring it has kind of disappeared. Basically, it's treated more by going by the symptoms, okay? So probing, if there's bleeding on probing, okay, well, it's active inflammation. If the pockets are getting deeper because they're being monitored, then it's active. So you could see here mostly spirochetes. Now, one interesting thing was the spirochetes, Dr. Kai showed us in our dental school, and he came and he debated with the chairman of periodontics, and he showed movies. They didn't have videos, and he showed a movie of spirochetes attached to calculus, and they were moving in a coordinated motion, like cilia. Can you believe that? They were moving in a coordinated, and his thought was, well, maybe because of the flow of fluid in the periodontal pockets, they were pushing out the white blood cells. Maybe that was an adaptive mechanism. But we know, in the course of evolution, we know mitochondria originally were bacteria. They have their own DNA, and very similar to that is the chloroplasts in plants. Of course, both the chloroplasts and the mitochondria produce ATP, and there would be an advantage for that bacteria and the primitive cell to merge together for energy production and oxidative respiration, or ATP production by photosynthesis. So who knows, maybe in 100 million years, spirochetes turned into cilia. Who knows? What's next? Okay, so here we have a lower jawbone, a mandible. Okay, so this is the part of the temporomandibular joint, where the lower jaw is connected into the temporal bone of the upper jaw. The bone here is what we call the alveolar bone. This is the bone that holds the teeth. The only reason for this bone to be there and form the sockets is to hold the teeth. And the teeth stimulate the bone, and they keep it there. You'll see down here there's a little hole. This is the mental foramen, where the main nerve supply, the alveolar nerve, goes through the alveolar canal through the bone, and it supplies all the teeth, and then it comes out through here and supplies the lip and the chin down in here. You'll also see, interesting, there's some horizontally impacted wisdom teeth in this mandible. Now, what happens when you lose all the teeth? Well, the alveolar bone resorbs. It disappears. It's no longer stimulated by teeth. And we see unfortunate people where this has happened. The bone has resorbed. You'll see here's the mental foramen is still there. But the bone is resorbing, and if you look in their mouth, you'll just see gums on top of this bone. How do you chew your food like that? Well, some people are very adaptable. Okay, and here's even further resorption. And look where the mental foramen is now. It's on top of the ridge. Now, if this person was wearing a full lower denture, it would be pressing on that nerve there. So we have to make sure that that's relieved. There's no pressure on it. But this is what can happen when the toothworm gets its way, and these teeth are lost. And this is a major, major effect on the person's nutrition, their ability to chew their food, to eat the right foods. They often go to a much softer diet. With loss of the vertical support that the teeth provide, also the temporomandibular joint is often affected. And it's just a huge change in the quality of life for the patient. And this is the tragic thing, this is all preventable, except it's just a lack of information that the general public has. So, I don't know, maybe you guys can spread the word, but people have to practice prevention, control the bacteria, control the frequency of exposure to sugar, and get their gums checked, get their teeth checked. Going back to the bacterial, the biofilm that's in these deep pockets, one of the things that's happening is it's producing what they call inflammatory cytokines, which are circulated through the body, and it has other effects on the general health of the body, the different organs. In particular, what I'm concerned about is the endothelial lining of the blood vessels, especially the arteries, and it's believed that this makes the lining of the arteries more reactive. So that in itself is a good idea, that you don't have all this inflammation going on in the mouth because of the cytokines which are circulated in the body. The other thing is that it's been shown that people with type 2 diabetes, if they have periodontitis, or that inflammation, that once that's brought into remission and it's controlled, that oftentimes the diabetes improves and the medication has to be adjusted. We know that people with diabetes are more susceptible to this kind of infection, but it's often unknown that it can improve it by getting rid of this chronic infection. Also, general health, it's been determined by statistics that it can affect the birth weight of babies and also premature birth if this inflammation is going on, because general effects from the cytokines and other effects that having all this inflammation in the body is happening. Oh, and the other thing is those inflamed gums, if we're concerned about transient bacteremias, it allows the bacteria to get into the bloodstream because the epithelial lining of the gum tissue has come off. And the epithelial lining, the gums are, if you consider your skin, you have your epidermis. The skin is a barrier. It's the barrier effect. It keeps the fluids in your body, and it keeps the bugs out of your body. The gums are the skin of the mouth. And when they become inflamed like that, and the lining of the tissue is ulcerated, bacteria gain access into the bloodstream. So a person that has that is going to have, and they're chewing on these loose teeth, all this inflammation, they're going to have transient bacteremias daily. So this is another risk factor. Transient bacteremias. And this is why when the surgeons are doing heart work or they're doing orthopedic work, they often send the patient to us to get a clearance to make sure that they're not having chronic infections like this going on, which could jeopardize the effect of their surgeries. What else we got here? All right, so, okay. So when the teeth are lost, one of the modalities that we use are dental implants. This is modern cylindrical type implant with threads on it, and this gets implanted into the bone. This is from the year 600 AD, a Mayan mandible from Honduras, and it has 3 implants made of seashells. Imagine that. And I think that they found that they probably were implanted in a live person, and that they were working. Different materials have been used for implants, and I remember back in the 70s, I was placing what they call vitreous carbon implants. And these are made out of carbon, and it was like a cylinder of charcoal, but it was much harder. And they worked great. They were implanted, but when you look at them on a radiograph, the carbon was radiolucent, so you didn't see the whole implant. You just saw the post that goes down. This is this was made very famous by Leonard Linkow back in the 60s and 70s. This is the blade implant, and what we would do is make a groove in the bone, and this was pushed into the bone. It was sutured over, and you have these posts, and this was used to replace missing teeth. The difference between this kind of implant and the cylindrical titanium ones that we use today is that the ones we use today, the bone actually fuses directly to the titanium metal. With these, this was more like, it was not a direct fusion of the bone to the implant. It was more like there was almost a ligament holding this, so it wasn't as tightly or as intimately connected to the bone. But they did work most of the time. I remember spending a couple of weekends in Dr. Linkow's office, and the first thing he told to the patients was, 20% of every implant I put in eventually have to be removed. You sure you want to do this? And they'd go, yeah. And he would do that, and he would use these blade implants. They're kind of out of favor today because the cylindrical ones are much more precise and a different mechanism of fusion to the bone. Okay, so this is an example where we put in some implants. This is a person with no lower teeth. His lower denture was bobbing up and down. The tongue would push it. It was very difficult to chew food. We put 3 implants into the anterior mandible here. And then okay, so in this particular case, we made a bar. This is going back quite a few years. We made a bar with spheres sticking up on the bar. So this is permanently screwed into the implants. The denture had reciprocal receptacles in there, and these particular ones had rubber O-rings. And the O-rings, when you put this on, the O-rings would snap onto the spheres, and guess what? The denture did not move. So this can be a huge game changer for somebody with a full lower denture that's having problems, as long as there's enough bone to put them in. There's different implants. There's even mini implants, which are very thin. You don't need that much bone. Okay. And there's the denture in his mouth. He was very happy with that. But we want to prevent this. We want to keep the teeth. They're meant to last your lifetime. We're not meant to be doing all this. This is slow. Okay. All right, some more examples of these cylindrical implants put into the bone. Here's an example where there's no tooth here, there's no tooth here. Have to be careful. There's the maxillary sinus. We don't want to have the implant going into the sinuses. So there they are in the bone. And then we made crowns on those implants. Okay, things can get really bad. This is 1993. This is my next door neighbor in New Jersey. Just so I show this, just as a couple of cases that you can see that even if you see someone like this, or you know someone or a patient, there is still hope, and we can do a lot. So this particular person, he was a truck driver. He also was doing forget what you call it. He was getting people to sign up for a network marketing with certain candy that you could use to give you energy. Another view of his teeth. Another view looking at the palate. There's the roof of his mouth. All these rotten teeth in there. Okay, here's what we did. We wound up doing, we fixed his upper front teeth. We had some budgetary restrictions. These were all fixed using bonded tooth-colored filling material. This was the state of the art of the filling material at that. This was 1993. So he was a happy guy. I sold my house and moved to a different location. I don't know how long this lasted. Hopefully he stopped eating the candy. Okay, this is another problem that we often run into as far as, this is gum recession. You'll see here's the crown of the tooth, the enamel goes up to here. This is, from here to here is all root. Now this gum recession is not due to periodontitis. This is due to the position of the teeth in the jawbone and also aggressive toothbrushing. Aggressive toothbrushing where the person's brushing too hard, they actually can push the gums off the roots. And this, of course, jeopardizes the survival of the teeth. All right, what can we do in a case like this where there's a lot of recession? Okay, this is alloderm. So we can do a graft. This is alloderm. This is a material that's basically collagen derived from cadaver skin, and it's treated so that there's no rejection phenomenon. Everything that would do that is removed. This can be used for grafting. That's what we did with this fellow. Okay, this is showing this method was without doing what we call a flap. This was done where we went underneath the gums and we went up and detached the gums from the bone so that the gums could be brought down, and the alloderm was threaded into the opening and then threaded all along in here and positioned so it covered the roots. Okay, so then what we do is we pull the gums down and suture it in place. So the gums, his own gums, are now covering the alloderm. And you see the sutures in there. It's hard for me to see it at this angle, but they're there. And here it is a month later. You still have some of these polypropylene sutures in there. Polypropylene is like fishing line. It's very non-reactive, and you can leave it in there for quite a while this healing is all taking place. This is 8 months later. So we got a very nice result, and it looks just as good today. It's very permanent result. Okay, this is another extreme case where we used a different method. You'll see this gum recession. As long as there's bone in between the teeth to support the gums, we can do this kind of procedure. So what would you do with a tooth like this? Would you extract it and do an implant or make a bridge? Well, we decided to save the tooth. And this is with a flap procedure where the gums are peeled off the bone and off the roots. This tooth, the tip of the root was exposed. The root canal treatment was done to remove the nerve, and a filling was put into the tip of the root. The root has to be grinded back a little bit so it's more even with the bone. And then what we use is what we call subepithelial tissue graft, where what we do is we take some of the gum tissue from the palate. If you take your tongue and you put it on the roof of your mouth and you feel over to the side where your back teeth are touching there, that's very tough, fibrous connective tissue. gum tissue. We take some of that and then we suture it with resorbable sutures over these defects. There's the palatal tissue, and then we suture the gums over that palatal tissue. So this is 2.5 weeks post-op. This is where the defect was. And this is 2 years later. And you can see it's the tissue is all keratinized. It's a tough, fibrous gum tissue here, which is not likely to recede again. And the nice thing about this procedure also is that it's the same color as the person's gum tissue. There are other methods of doing this, but anyway, there are things we can do to save a tooth even with that severe gum recession. The thing is, well, don't brush too aggressively where you're pushing the gums off the roots. People will often scrub back and forth at the gum line and overdo it and also cause grooves in the roots. We call it toothbrush abrasion. Another word is cervical abfraction, where some people believe clenching the teeth will also cause that type of a problem. So this is a person. This was an elderly lady from Germany, and she was a mess. Now, not only were the teeth rotting away due to decay, also we had severe attrition of these lower teeth. This is from grinding the teeth together, rubbing the teeth together all the time. And having lived through World War II, she probably was under a lot of stress in her life at that time and carried over. But when she bit down, she had this collapsed bite, you see. She was missing so many teeth. These teeth that were worn down by attrition were practically hitting the gums here. Now, it used to always be thought that this attrition or bruxism, grinding of the teeth, occurred mostly in sleep. And there were recent studies done where it's been shown that probably most of the grinding of the teeth is during the daytime. So night guard helps when you're sleeping, but during the daytime, what I tell people to do it is play a little game called Don't Let Your Teeth Touch. And when we were kids, we had a superstition, which was if you step on a crack, you'll break your mother's back. So we were walking to and from school on the sidewalk. We never stepped on cracks, even though it was ridiculous. But we had that in our mind, and it was a superstition. And make this a superstition. It's not good if your teeth are touching. Keep them always a little bit apart because it's probably triggering a clenching and grinding reflex. Subconsciously, you don't even know you're doing it. Anyway. Okay, so she needed some root canal treatments on some of these front teeth, which were down to the gum line, so the pulps or the nerves were removed. This is looking at the palate here. It's easy to get disoriented with these photos. But okay, so now the top teeth, these were all built up. These were all built up with posts and composites. And then, I'm almost done, hang on. Okay, this is what we achieved. This is crowns on the teeth, and these were the ones that were worn down. And she was happy as a lark. And she took this with her to her grave. So it was definitely life-changing. Okay, another quickie. This is a panoramic x-ray, just so you could see sometimes we do lots of root canal treatments and build up of these teeth. Root canals everywhere. You see there's the maxillary sinus up in there. So all of this can be done. Another gruesome thing, this all could be prevented. This could all be prevented, and this is why I'm kind of passionate about trying to get the word out, but it's lack of knowledge, it's lack of understanding of what causes it, and it's basically, and this particular fellow, okay, these teeth were crowned on the bottom, and that's what he looked like. And then we did some implants on the posterior mandible to give him some teeth that are not removable. I'm almost done, don't worry. And this is on the other side, implants. These are these implants were cemented, the crowns were cemented on the implants, and this shows some crowns cemented on the implants on the back teeth. So that made a huge difference in this guy's life. But he let it go way too far. Okay, this is what we want, just natural, beautiful teeth. And that's the end of the presentation. Thank you.
Dr. Veit, thank you so very much for that informative presentation. A lot to chew on there for us. Welcome back, everyone. I hope you enjoyed that short break and got some refreshments. We move on to our final session on our health, advances in cancer diagnosis, monitoring, and management, a panel discussion that will be moderated by Dr. Delroy Jefferson, who's the medical director for the Cayman Islands Health Services Authority. And he'll be joined on the panel by Dr. Lundie Richards, Dr. Courtney Cummings, Dr. Darley Solomon, Dr. Vineetha Binoy. We're excited to have such an esteemed panel, and we look forward to the discussions. I will now hand over to Dr. Jefferson.
Thank you, Mr. Masters of Ceremony. So we've come to the penultimate presentation for the day. We've had a very impactful conference, and I'm sure you can all agree that we've learned quite a lot. Now, we have with us an esteemed panel who will be discussing something that is very dear to us. I mean, as you listen to the conference over the past 3 days, this is the third day, you recognize that there is a common thread that cancers are very important to the population within the Cayman Islands. The various presentations have drawn our attention to that important disorder. The planning committee recognized that there was a need for us to look a little bit more closely at cancer. The committee wanted to draw attention to two important issues. The first issue is that as a country, we are fortunate in having a very good team of experts drawn from the three major facilities. And represented on the panel are members from the Cayman Islands Health Services Authority, Health City Cayman, and Doctors Hospital. The significance of this is that we now are able to collaboratively address several cancer-related issues that in times past we were not able to address. The second issue is that there are advances made in cancer. And the committee, the panel, will be looking at some of these advances and will be affording you the opportunity to ask questions. So let me now introduce the panel members. Dr. Courtney Cummings, he is a consultant physician at the Health Services Authority. He has a doctorate in internal medicine, and he currently serves as the Deputy Medical Director at the Cayman Islands Health Services Authority. He was a former acting medical director for the HSA, and he now chairs the Stroke Protocol Committee. He's a CME coordinator and a member of the Antimicrobial Stewardship Committee. He also is a member of the Clinical Practice Review Committee, and he also is one of the key persons on the National and the HSA COVID Task Force. Then we have Dr. Vineetha Binoy. Vineetha practices as a consultant medical oncologist at Health City, Cayman Islands. She's trained in internal medicine and medical oncology and hematology, and she's also trained in hematopoietic stem cell transplantation at various prestigious institutes in India and Australia. She has over 15 years of experience in oncology, and as a firm believer of comprehensive cancer care, her focus is on the prevention, screening, early detection, diagnosis, and multidisciplinary management of hematological and non-hematological malignancies. Then, sitting next to Dr. Cummings, we have Dr. Lundie, who you've heard from yesterday. Dr. Richards is a consultant medical hematologist-oncologist at the Health Services Authority and has been part of the organization's internal medicine, pathology lab, and hematology oncology team since 2019. Prior to joining the HSA, he was a visiting specialist to oncology patients on Ireland. In addition to hematology and oncology services, he provides expertise in public health, blood bank, and transfusion medicine. Last but not least is Dr. Darley Solomon. Dr. Solomon is an attending general surgeon at Doctors Hospital, specializing in treating patients with abdominal pain, hernias, gallbladder, colon, and breast complications. Dr. Solomon obtained his Bachelor of Science in Chemistry at Howard University in Washington, D.C., where he also received his MD. Dr. Solomon has practiced as an attending and consultant surgeon in both Mississippi and the Cayman Islands. He's a member of the Mississippi State Medical Association, the American Medical Association, and the American Society of General Surgery. I've given you a snippet of the caliber of persons on Ireland who are available to collaboratively provide care in cancer treatment. Please put your hands together in welcoming the panel. I'll say a brief note on how this panel discussion will proceed. Initially, we'll have Dr. Cummings giving a general overview, and then each panel member will spend a few minutes highlighting specific aspects of cancer, at the end of which we're anticipating that the audience will be providing questions to the panelists. So without further ado, could Dr. Cummings come to the podium, please?
Thank you, Dr. Jeff, and a very pleasant good morning to you all. I want to add my voice to that of speakers before me in congratulating the organizers of this conference and for inviting me also to come along. As Dr. Jeff said, I will be giving an overview of cancer, albeit a very brief overview. And so I want to start by agreeing with you what the diagnosis of cancer is. It's a disease of uncontrolled, abnormal division of cells. And those cells have a potential to spread to other areas. We agree, and thank you for agreeing with me. In order to make the points that I'd like to make quickly in the time that is mine to share, a very brief time, they told me, I want to talk to us about the basic structure of the atom, a bit of physics, if you don't mind. The basic structure or the basic relevant structure of the cell, and then I want to talk about cellular division. And then I want to talk after that about tumor markers. And if time permits me, briefly, we'll talk about the modalities of cancer investigation and treatment. If you will, look at me, please, on the left-hand side of that slide, you'll see that's a pictorial representation of an atom. An atom is the smallest particle in terms of matter, the smallest. And it has at its central part, there's the nucleus, which consists of the, as you can see there, the protons, which are positively charged particles, and the neutrons, which have no charge. Orbiting around that nucleus are what we call electrons, and they are negatively charged. And so you will see that the electrons and the protons, they are equal in number. So one has positive charge and the other has negative. So the whole atom is stable because they neutralize each other in terms of charge, electrical charge. But the electron that is there orbits the neutron just as the planets orbit the sun. And they do that very fast. How fast? I'm glad you asked me. Somewhere I read that they move at the speed of 2,200 kilometers per second, Dr. Jeff. That means it would take about 18 seconds to go around the Earth. We're still in physics, don't worry. We get off of physics just now. And it's so fast that we can't see it. All you see is a cloud going around the nucleus. That's all you see. Whereas you can see other things, you can't see the electron. So they're full of energy. And I want to say to you that the electrons, as that slide shows, they are, hold on, where are you going? Right. It shows there are different orbits. And the point I want to make here is that these different orbits have different energy status. Hold on. The electrons, those electrons, they hang out in pairs only, or they like to hang out in pairs. So one of the points I want to make right now is that when in any of the orbits, orbit 1 or 2 or 3, this is just a pictorial representation, if there's an uneven number or unparalleled electron, that electron is unstable, and it tries to capture another electron from somewhere else, or it tries to give up its electron to somewhere else to become stable. Hence, with that, what they do, these atoms, they join up with each other. Another atom here, and another one here, and before you know it, you have 2 or 3 or many atoms forming a molecule. And that molecule joined together by different bonds, covalent, hydrogen bond, ionic bond, whatever it is. They join together and form one large molecule, which could be protein, lipids, whatever it is. And it's that collection of molecules that will form a cell. And you see what I have it here. So the atom, many of them, in fact, a cell consists, and it's here, of trillions of atoms. So many atoms combine to form the constituents of a cell. And so the atoms form molecules which then eventually form cells, and then eventually form an organism. You understand that? So the cell. I want to show you that the cell, and the important part of this that I want to tell you about, is just the nucleus of the cell. But bear with me. The cell has the organelles, the ribosomes, the mitochondria, and they all comprise atoms. Atoms make them all up. That's basic. We understand that. We agree on that. But we want to talk about the nucleus of the cell. That nucleus contains the chromosomes, And if you were to, you know that there's 23 pairs of chromosomes in adults, in humans. And if you were to take the chromosomes and strip them out, you'll find the DNA. The DNA is nothing more than a miles-long length of atoms and atoms and atoms and atoms. And every quarter mile, I'm just using that term, is a gene. So you got a gene for hair color, gene for skin color, gene for height, etc., etc. So in other words, packed in this nucleus, you have everything that determines how you look. All the things that you got from your mother, and unfortunately from your father also too. But this slide tells you more or less what I just said. Right. And so one of the points I wanted to make here before I get on to this slide is, if you noticed, just go back to that the nucleus contains that DNA, the chromosomes, that determines everything. But the chromosomes, the DNA, is made up of atoms. You remember that? And the atoms, they join together. And what I want to say here now is that the cells of human body, all our cells, are continually bombarded by things that can damage the DNA. What things are that you ask? Well, let me tell you since you asked me. The things are ionizing radiation, chemicals, drugs, viruses. The bottom line is, all of these things, what they do, they tend to affect the atom and thereby affect the molecules. Because remember that atoms are joined together. And what I should tell you quickly is that, so you have an atom, and we said that when the electrons, if the electrons are not paired, it becomes what I call unstable. So an unpaired electron will look for another electron. And what these things do, ionizing radiation and some of the other things that I mentioned, they will move electrons from off the atom. No, you understand? So exposing someone to ionizing radiation, all you're doing is moving electrons, and you're making these atoms that are in molecules very unstable. Not only that, the unstable molecule that remains there, or atom, becomes like what we call a free radical, reactive oxygen species. Not to confuse you. In other words, it starts to look for somewhere else that it can attach to. So when you move that electron from that atom, we can pack our bags and go home right now. That's the electron. When you move that electron from off that atom, it looks for other places to go, and it pulls off for the DNA, it pulls off for the lipids, pulls off everything. But importantly, it's the DNA that is damages, and when that DNA is damaged, then other things happen. I want to quickly say also, the problem with radiation, it not only damages the DNA, there's something we have that is called the DNA repair genes. It always stops and it blocks that also. We're going to see that in more detail. So come with me. Let me show you, first of all, that cellular division, which we want to talk about, simply is that cells, there's a mother cell. There's a mother cell here. You can see that mother cell here. And the mother cell replicates the DNA. So there's equal amount of this is supposed to be 23 pairs. You can see that, right? I can see that. Just say yes. You can see it. 23 pairs, even though it's one. But it's duplicated. So you get exactly a duplicate of this. So you got 4 now. So 2, now 4. So 2 on each. And eventually that cells divide, and there are two daughter cells that contain exactly the same genetic component as the mother cell. We're doing that. And so I learned from my Sunday school teacher that division is really multiplication. You see there? And so I want to show it on another, I know my time is, yeah. This other slide, very important you get this. So this is exactly what I just said there. But I want to use a term which is going to be important for you to understand this lecture and what my good people behind me will say. So this is the same cellular division where the mother cell divides into two daughter cells. And here you have what it is that cell, if the cell were in the resting phase, you call it the G0 phase. But it's in the G1 phase because some cells don't divide, like the brain cells and the muscle cells. We're not talking about that. We don't want to talk about that today. But the G1 phase, what happens, this cell, let's say it's an epithelial cell from the intestines, instruction is given for it to divide. So what happens, the proto-oncogenes, this gene, sends a signal so that it pushes the cell from the G1 phase to the S phase. So it pushes on, because the full cycle is G1, S, G2, then M. And then, this is normal cell division we're talking about, and you got the tumor suppression genes, they do something else. They usually inhibit the transition to the S phase. So when that cell gets the signal to divide or to multiply if you want, what it does, this is activated, and this is blocked. So the cell can divide properly. Okay? Got that? So the next slide will show you this now. So that's normal. That's normal. I want to show you this quickly. And in cancer now, what happens? In cancer, the proto-oncogenes are permanently turned on, right? They're turned on. And so the cell is moving from the G1 phase to the S phase. It's going on with division, right? And the suppressor genes, the tumor suppressor genes, are turned off. Nothing blocks it. So now you understand there's a constant production of cells with no limitation. This is why I started and I said it's uncontrolled division of cells. My first slide said that. But there's another thing I want you to take note of here. The DNA repair gene malfunctions. That gene should, whenever it sees abnormal breaks in the DNA, should shut it down. That is what a gene, once it recognizes something abnormal, it should say, shut down. But that is malfunctioning too also. So these three things happen and produce cancer. And so I agree with Dr. Richards, who said yesterday, and I almost call him Dr. Jonathan. But that's a prophecy too. I'm giving prophecy here too, by the way. That tells you it's a genetic disease. So cancer is a genetic disease. This slide shows you exactly what I said before. It's in a beautiful way. In cancer, the oncogenes, you see what I said? They're permanently turned on. They're pushing the cells to divide. And the tumor suppressor genes are permanently turned off. There's nothing blocking it. So guess what? There's a production of cells that are abnormal now. And if I had time, and I don't have time, I would have told you that the cells clearly in the cancer cells, because the DNA has been altered, the radiation has damaged the DNA, so it's a different type of cell being produced. So you're getting excessive production of these abnormal cells for the reasons I mentioned. And so this slide says exactly what the good folks said yesterday. It shows now the tumor markers. And we have a whole host, and I know Dr. Richards said it ad nauseum, we went through this yesterday. And not only the list of tumor markers, you can see them here, tumor markers, but also the approved therapy. And that's the benefit of the genetic testing, which my colleagues will probably talk about in specific cases. But now we know we can actually document the tumor markers in individual cancers. And because you can do that now, we can target him, the so-called targeted therapy. And so this slide, again, says more or less what I said just now. But I want to bring your attention to one point down here, this one here. This targeted therapy is the basis for immunotherapy and cancer vaccines, such as the HPV vaccine that we give to patients. And it's because of targeting and finding out what the tumor marker is. You can then predict now what treatment to use. All right. So I'm going to quickly say, get out of here, Dr. Jeff. I can see your eye. I see that evil eye. I see the evil eye. I see it. This slide simply tells you, based on all the things we said, and my colleagues will go into some more detail, the things we can do to investigate the patients and all the treatment. Dr. Richards and Jonathan went through in detail. I could have taken this slide out. All these things yesterday. They went through monoclonal antibodies, etc. Radiation therapy. I'm going to end here now. Radiation therapy, so is the same principle. So when you give so a patient has a cancer, and what happens is that the treatment is so good now. First of all, we can give like a pencil point. We can pinpoint a tumor and just go straight for that tumor. Now, prior to this time, prior to this era, when we give patients radiotherapy, we would give them radiotherapy and we damage other things. We damage the bowel, we damage the skin. No, we're different now. What we do, we give exactly to the location, as I said, pencil point. And they give that treatment. And why is it effective? Because what are you doing? You're actually, the cancer cells that are proliferating now, you hit the electrons off of the atom for the cancer cell, and guess what? It destroys it. And that's really what it is. So it's not only that this ionizing radiation is bad for good cells, it's bad for bad cells also. And I think I'm going to stop here. And thank you very much for your time.
Good afternoon, all. I'm nearly there. First of all, let me thank the Ministry of Health and Wellness and the Health Services Authority for giving me this opportunity to take part in this panel discussion. Dr. Cummings has made the job of the rest of our panelists easier by his detailed overview. It's an overview, but it's very detailed, and it makes our job easier because these are the very things that we are going to touch upon in our panel discussion today. So I'll be discussing some new concepts and strategies focusing on breast and lung cancers. And on top of that list is what we call precision medicine. And for those of you who attended Dr. Richard's talk yesterday and also Mr. Smelly's talk, we all know now that cancer is genetic in origin. And we talked in detail about the genomics of cancer yesterday. And just like every single individual in this hall has a different genetic makeup, everybody is unique, all cancers have different genetic makeup. We now know that. So we cannot treat all cancers the same, and it's important to know the molecular signatures of each cancer before we decide on the best treatment. And this is what we call a personalized cancer medicine, which is, every person needs to have his own treatment plan. And you cannot treat everybody the same. So that is precision medicine for you. I'll be coming to that a little bit in detail. Then the next one we have is one of the greatest breakthroughs of this decade is cancer immunotherapy. So we know that we have an immune system that fights and protects our body against viral infections, bacterial infections, and so forth, but a part of the immune system also takes part in cancer surveillance and destruction of cancer cells. And most of the time when we have a cancer in the body, it's because that part of the immune system is weakened or the cancer overrides that immune system. And now we have several immunotherapy molecules, which could be antibodies. It could be what you call CAR T-cell therapy, which is specifically engineered T cells. It could be cancer vaccines. And they have led to outstanding improvements in survival in many cancers, advanced cancers of the lung, melanoma, kidney cancers, and all. To give you an example, the first cancer immunotherapy in Cayman was an elderly gentleman with stage 4 lung cancer. This was 2016. At diagnosis, he had malignant pleural effusion, that is fluid in the lungs. He had extensive liver metastasis. The liver was riddled with tumor, extensive bone metastasis. So the standard of treatment that time was chemotherapy. And as all my oncology colleagues know, for lung cancer, chemotherapy is very difficult. Survival rates are only 6 to 9 months. Most people do not tolerate chemotherapy very well. And this gentleman was going the same way. And he was not responding to chemo. He was doing very well. He had very, very badly affected by toxicities like neuropathy, anemia. And it was then that the approval for the first immunotherapy came. Luckily, we were able to procure that drug. We got insurance approval, and I gave him the first infusion. No guarantees. The family was prepared for palliative care. And then I went on a vacation for 3 weeks. After his first infusion, I didn't hope to find him alive when I came back. I was expecting bad news. When I came back, I was surprised to see he was still alive, looking better, feeling better. And to my surprise and everybody's happiness, after 3 more cycles of immunotherapy, all his cancer was gone, literally. The liver was clean. I think I've shown this PET scan many times in previous presentations. His PET scan was clear. No metastasis, nothing. And this was, such a, we were like so happy with the outcomes. And since then, there have been, all hospitals in Cayman, we've been treating patients with immunotherapy on a regular basis, sometimes with fantastic results. I've had at least 2 patients with stage 4 lung cancers, one with tumors in the brain, who has gone into complete remission, what you call, just with immunotherapy. And the remission has been maintained, the response rates maintained for 2 years. I have been able to take them off immunotherapy. So stage 4 cancers, lung cancers cured, melanomas cured, or in remission at least. When we reach a survival of 2 years in remission, complete response, we might gingerly call them cured, even though we are keeping them under follow-up. So these kind of outstanding results are, we see with immunotherapy. Mind you, not all cancers, not all patients, but some of them for whom it works really well. We also have at least 4 or more than that, and at least in my experience, patients with refractory blood cancers who have received what we call CAR T-cell therapy in the States, and they are in remission. So these are very difficult to treat refractory blood cancers, but they have gone overseas, got CAR T-cell therapy, and they have gone into remission. So this is cancer immunotherapy, and now we know that, according to data from the United States, at least 40% of cancer patients could derive a benefit from immunotherapy. And almost 60 to 70% of cancer patients derive a benefit from targeted therapy. So that's where we are headed. So we also talk about a new strategy, which is risk-adapted screening and treatment of patients. So we do not treat every patient the same. For some patients, some tumors, we assess their risk. What is their risk of the cancer coming back? Is it very high risk? Then we do more. Low risk, we do less. So sometimes less is more for patients. For example, breast cancer patients with very high expression of estrogen receptors, we do what is called a molecular signature testing, and that can tell us whether the patient will benefit from chemo or not. And a lot of the time we find that, okay, the test tells us that this patient will not benefit from chemotherapy, instead give only hormone therapy. So we are saving the patient from from the toxicities of chemotherapy. And sometimes some patients with very high risk disease, it could be cancer genetics or own genetics, will need more. For example, somebody with a BRCA gene mutation, they are at a very high risk of developing secondary cancers, bilateral breast cancers. Sometimes, if the patient has a breast cancer, it is better to remove both breasts to reduce what we call a bilateral risk reduction mastectomy, to reduce their risk of a cancer in the other breast. So, looking at a patient's risk factors, individual characteristics, it could be the tumor characteristics or the patient's own characteristics, we are able to adapt the treatment to their risk. And of course, we have new combinations of existing treatments. We must remember that one of the pillars is chemotherapy, radiotherapy. They have not gone anywhere. They will still be around, but we are finding fantastic responses and improved outcomes, survivals, lower recurrence rates when we compare the standard chemo to immunotherapy and various targeted therapies. So you're looking at new combinations of existing treatments. We also look at new drug types. For example, the antibody drug conjugates, or ADC. Probably all of us have heard about the drug called Herceptin, which is used in breast cancer. It is a targeted therapy, an antibody which binds to the HER2 receptor on breast cancer cells, and it's a revolutionary drug, actually, which has saved the lives of, I would say, thousands or millions of breast cancer patients. What we have found that this drug could be, you could add a chemotherapy molecule to it. It's like a piggyback. So the drug goes and binds to the HER2, the Herceptin part of it binds to the HER2 receptor, and then there is a payload of a chemo drug, which kills the cancer cell. So the additional benefit, the drug goes only to the cells which have HER2, it delivers the chemo directly and enhances cell killing. And what we are finding is that this drug has been much more effective in treating advanced breast cancers than after progression on Herceptin. We also talk about repurposing drugs for oncology. So we have some drugs which are approved in certain cancer types. We have been using them more and more for other cancers. One example is Herceptin. It started off as a breast cancer drug, but later on we found that gastric cancers, colon cancers can all have HER2 receptors. Now the latest one on that list is lung cancer. So even lung cancers can express HER2 receptors. So we try Herceptin for these cancers too, and they work. For those who have the HER2 overexpression, they work. And the entire basis of repurposing is that we already know the drug, we already know its side effects, so it doesn't take much long for approval, it's not so expensive, and it works. So, and we also have other non-cancer drugs which can help in addition to the treatments. For example, the drug metformin, which is very commonly used. We know diabetes. Metformin has been found to target some receptors called mTOR receptors in cancer cells. So studies are underway where we can use some of the cheaper drugs as adjuncts in cancer treatment. And we also have broadly, we tend to treat, as a part of personalized medicine, we want to treat the patient as a whole. And we cannot forget the concept of integrative oncology, where we bring a whole lot of supportive services, including palliative pain and palliative care, to the management of cancer patients. So integrative oncology is a very, evolving and well-accepted strategy in treatment of cancer. So I just wanted to focus a bit on liquid biopsies. So Dr. Richards spoke extensively on liquid biopsies yesterday, for those who are not here. It uses a blood sample. It can also use a liquid biopsy because we are using the blood. It's a very easy way of getting hold of some tumor cells. So it usually works in advanced cancers very well because they have a lot of circulating tumor cells. But even patients who have early cancers could have some tumor cells circulating in the blood. And we extract them, or the DNA, from the blood sample, and we run a whole lot of gene testing, or panel testing on it, identifying all these different, what we call the mutations in the cancer cell. And we can use this from early diagnosis to the treatment. So now several tests, the holy grail of cancer screening is a test that could pick up cancer, a blood test. Everybody asks me all the time, do you have a blood test instead of all the mammograms and the scans? When will we get a blood test that could tell us whether you have cancer or not? Well, it's not yet there, we are not yet there, but something might be in the horizon, and a lot of research going on, but you could just take a blood sample, run the test, and it could possibly tell you, you have a 40% chance that you have a pancreatic cancer, get yourself tested. Maybe go and have that MRI. And when you have early cancer, you finish, for example, a breast cancer, or blood cancer, it is used commonly in blood cancer. When somebody is in remission, the bone marrow is clear, you do a liquid biopsy, it can run some tests and say, okay, do you still have a little bit of cancer cells left that you cannot see on the bone marrow under the microscope? Then we intensify the treatment. And of course, as I said, for cancers which are metastatic, advanced, and refractory, finding new and new molecular markers will help us. For example, a patient of mine who's a relatively young person presented with extensive metastasis in almost all organs in the body. The bones are full of metastatic disease, the lungs, he had deposits in the skin, in the muscle, in the brain. And usually a pathologist tells me where the primary cancer is from, or the radiologist. Okay, there is a tumor in the lung that is prominent, this is a primary cancer. This gentleman we couldn't say because the lung nodules are very small, they didn't look like primary lung. And everywhere we couldn't find a primary, and the pathologist told us it could be from the gastrointestinal tract because it was a mucinous type. So usually a pathologist is our best friend, but with liquid biopsies, I now consider molecular biologists my best friend. So Jonathan is here, but my pathologist Jyoti is not here, thank God. She won't give me her next biopsy. And we ran the test, Foundation 1 liquid biopsy, and it came back showing a mutation or a marker that told me this is a lung cancer. So you have to treat it as a lung cancer because the primary is lung, which the pathologist could not tell me even with the comprehensive testing. And then, so the liquid biopsy is a standard practice now, but we do have a lot of issues because we have to explain to patients what it is all about. Just the other day, one of my elderly ladies, I wanted to get lung cancer, want to run marker testing liquid biopsy. Explained everything to her. She probably didn't understand. She got the consent form. She said, "You are making me a guinea pig. What is this? What are you going to do with my blood?" So it says the blood will go into a tissue repository. She didn't understand what it meant. So she was all up in arms against me, but I had to spend an hour to tell her what it was all about. Now, where we stand right now in cancer care, we have the traditional pillars of surgery. Obviously, a surgeon is our best friend. Radiotherapy, the traditional cancer chemotherapy, and we also have precision therapy or targeted therapy, and we have immunotherapy. So just two brief snippets of two cases, one breast cancer and lung cancer. So these are the two commonest cancers all around the world and also in Cayman. I know the data didn't mention lung cancer at all, but from our experience, Dr. Richards will agree that lung cancer also tops the commonest cancer, especially in men, maybe after prostate. So this is a 35-year-old lady, a very young lady. She found a lump in her left breast. And then after mammography and ultrasound, they found a tumor biopsy. They found that the cancer is in the breast as well as lymph nodes. It is a triple negative type. That means it's estrogen receptor negative, progesterone negative, HER2 negative. So all three standard markers are negative. We know the triple negative cancer is one of the most aggressive kind of breast cancer, very high growth rate and spreads fast. About 25 years ago, we didn't even know that something called a triple negative cancer existed. We didn't know that terminology at all. We thought all breast cancer are the same. So at 20 years ago, we would have stage 2 cancer. The surgeon would have come in and operated on her, removed the breast. She would have got chemotherapy, which is quite standard, and maybe some radiation. But now we know it's not like that. We need to ask her more things. So when we went to the family history, she had an aunt who had breast cancer at a very young age too, and she's triple negative. She is young. We need to do what we call a BRCA testing. So BRCA gene mutations, everybody elaborated before. It's a DNA repair gene. If there is a mutation, people develop cancers. This is a patient with standard treatment. We would not run or rush into surgery now. Given that she had cancer in the lymph nodes, we'll give her chemo and immunotherapy first. Following surgery, she also needs adjuvant immunotherapy. And of course, if she had a BRCA mutation instead of immunotherapy, we'll give her what is called PARP inhibitors. So we can comparing what it was 2 decades ago, just surgery, blanket chemo, and then maybe some radiation, and leave her to her fate, exactly what we are doing. And more than 50% of these patients used to have recurrences and metastatic spread. But with this, this is how we personalize her treatment. And second case, a 74-year-old lady, never smoked in her life and now diagnosed with lung cancer, metastatic with pleural effusion. And she also has bone metastasis. And now, as I mentioned, about 10 years ago, we would have just given her chemotherapy, the standard chemotherapy. Being 74-year-old, she would have never tolerated it more than 3 months. She would have died in 6 months. She would pass away. But this time, we did biomarker testing, both on the tissue, the biopsy, as well as a liquid. We found that she has what you call an EGFR mutation. And in my tumor board, my colleagues often make fun of me because it's always A, B, C, D, X, Y, Z mutation. And now they know all about it because I've trained them well enough. So our chief of anesthesia always says, whenever I talk about liquid biopsy, is there EGFR mutation? That's the only thing he knows. So one of the commonest mutations in this age group, non-smoker, and this makes her eligible for a targeted therapy, which is a pill called, we use Tagrisso, so there are several pills available. People with advanced cancers like this could live 3 or 4 or even 5 years on that pill. So she received the targeted therapy and still doing well. So as far as we are concerned about cancer treatment, the one-size-fits-all store on sale is going to close down. But I would never recommend you going there and buying something on discount. Please not. So let everything expire. We are not going that way anymore. So that's what we are looking at in the future. The cancer moonshot, hopefully, will become something true in the near future. Thank you.
All right. Well, ladies and gentlemen, you've heard from Dr. Cummings, you've heard the fact that he explained up to the microscopic level what's going on within the cancer cells. And you've heard from Dr. Binoy that we've moved away from the former dispensation with respect to the management and the treatment of cancers to now there are much more modern techniques. I'm going to be turning the attention to the panelists, and I am going to be stimulating the discussion by asking a few questions of Dr. Darley, Solomon, and Dr. Lundie, and then I'll allow you the opportunity to ask questions as well. My first question is to Dr. Darley Solomon. We've had a number of, we've heard, for example, that we've moved away from the era where everything was you debulk, you big massive surgeries to remove the cancers. And now we're moving away to what's called minimal invasive cancer. Dr. Solomon, in your opinion, what could you say about the new technologies with respect to the minimal invasive cancers, the minimal invasive treatment of cancers?
Well, first of all, thank you all for being here. This is an important topic, especially here in the Cayman Islands. There's a lot of progress from a surgical point of view. We are, believe it or not, even from my point of view, we are doing less aggressive surgery. And that is a good thing, because with surgery comes comorbidity or injuries. For example, when they were doing radical mastectomies, it was quite common to have women with lymphedema of the arm, which can be debilitating, wing scapulas, so they lose motion of their shoulders. And in 73, that's how long breast conservation surgery has been recommended as a standard of care. And so along the way, I think it was 99, we started saying that, well, you may not need to do axillary node dissections. Maybe you could do sentinel node dissections. So that was 1999. And now it's progressed to the point that they're doing studies to evaluate whether you can just radiate the axilla and not even have to do sentinel node biopsies. So we see the progression, and the precision medication and immunotherapy that Dr. Binoy talked about is going to make even further advances. So the future looks bright, and surgery may be on the decline in terms of the aggressiveness. For example, we're doing more nipple-sparing mastectomies. We're doing more skin-sparing mastectomies. And all of these in the studies show that they're comparable. And these are for people who just may have multicentric disease. And it's been proven that the overall survival is comparable. And we're getting to the point where we're measuring the extension of lives in months. And, you know, that initially I was like, well, that's not a whole lot of time. But when you think about maybe a parent who gets 3 more months and gets to see a child or a grandchild born or a child married, then that's a significant life marker. So we are making progress, and I think that, as Dr. Binoy said, the moonshot is within our reach. I'm hoping within our lifetime.
Absolutely. Thank you for that answer. So yesterday, Dr. Lundie made the comment that cancer once upon a time was a life sentence once you were told that you were once the diagnosis of cancer was made. But over the years, there's been a change, and it's now entering into the realm of a chronic disorder. And that's because there are a number of newer modalities of diagnosis, newer ways of finding out what's going on, newer ways of monitoring what's going on, and newer approaches with respect to treatment. Dr. Lundie, in today's complex landscape, there are multiple modalities of treatment for prostate cancer. Of course, it's of interest of my very first and second and several other speakers and myself, and I'm sure it's the same for most men and their wives, this issue of prostate cancer. And we have to choose what's the best way to treat with the least associated complications. From your perspective, when you navigate the minefields, what do you see as the best option for the treatment of prostate cancer?
Dr. Jeff, that's a trick question. Because the best option for any for the best treatment option for any condition, it always depends on stage of diagnosis, which means that if you have a localized cancer, meaning the cancer is at one little spot in the prostate, the treatment is different from if the cancer has spread to other areas, including distant places. Right? So that's the first thing. And then we also look at how aggressive is this cancer. And so we move from probably some form of minimal surgery at the beginning, and that's I'm treading into the fields of the urologist, to where, like a case that I wanted to present, where patients may be given what we call neoadjuvant therapy, which is giving hormone and chemotherapy before surgery to shrink the size of the tumor, especially if it is localized in and around the prostate, and then go on to have surgery. Surgery is almost always, I believe, an option has to be done in prostate cancer, almost always. But of course, we have that kind of stage in which we say, okay, the role of various forms of radiation therapy, whether it's beaming the whole pelvis or whether it's planting of different seeds. And so that also depends on the physician's comfort and the physician's preference along with discussion with the patient. There are some which you know that, for example, if a patient has prostate cancer that has spread all over the body, we know what the modality of treatment is. It's usually hormone treatment for the rest of their life, or, along with other supportive therapies. But that stage where it is, let's call it, they go into remission. I don't use the CURE word. When they go into remission, then surgery plus or minus radiation, or radiation plus or minus surgery is going to be very important.
Thank you. My last question before, and this question is to any member of the panel who may wish to answer. It has been opined that anecdotally the Cayman Islands has a higher incidence of cancers relative to the other regional territories. Now, we know this is anecdotal. What are your thoughts? I mean, how do you see the Cayman Islands comparing with the other regional territories with respect to the incidence of cancers? Any member of the panel could answer.
Well, I'll jump in there. I think that to answer you, we don't have the numbers locally, and I think that is a significant problem. Usually when I do a talk, I have to resort to utilizing U.S. Numbers and demographics. And while that's relative, it would be better to have the specifics of what occurs locally, because that's going to impact your whole healthcare system in terms of how you manage, you treat, and it will eventually impact lives. For example, if you have a patient that is developing a particular type of cancer, what are the things that we can educate the public about? I don't think, correct me if I'm wrong, but I don't think if anybody in this room has the exact number of colon cancer, breast cancer, lung cancer, prostate cancer, melanoma that occurs in this island. And until we get that, we're not really being serious about cancer.
Dr. Jeff, I just want to add, I echo what you're saying, Darley, and I agree totally with you, the whole aspect of having data. And the current method of capturing data is voluntary. People volunteer to say, to register their diagnosis with the cancer registry. But that is not enough, because we see a number of patients all the time who say, nope, I don't want my information to be there. And in fact, this information is actually anonymous, right? It's totally anonymous. And the cancer registry doesn't know whether it's John or Jane or Mary. They don't really know. And so I think it's now time to turn to the legal luminaries to ensure that a cancer registry, that we have obligatory registration once a cancer is diagnosed.
Thank you very much. Now the floor is open. The panelists are at your disposal. If there are any pressing questions that you may have, especially around the newer modalities of treatment, now is the time to ask your questions, direct your questions to the panel. I don't know if there is a mic that is a floating, fantastic. So there's a floating mic. Any questions you have of the panel? Okay.
Hello, good morning. Thank you for a really good presentation. I'm piggybacking on your question, Dr. Jefferson. Anybody can answer. It's relating to prostate cancer. So Dr. Lundie did a very good answer in terms of choosing surgery, radiotherapy, chemotherapy, but hormonal therapy. But are there any newer modalities, like when Dr. Binoy was mentioning about, the immune therapy targeted? Is there anything like that happening for prostate either now or in the pipelines?
Yes, there are certain targeted therapies that are now being used or are in experiments, so to speak, in research. And so we expect that to improve. And not only that, the type of chemotherapy that is used, that too is changing over time. And of course, we know every day there's a different type of androgen therapy, different type of hormone therapy coming out.
Thank you. Any other questions? Thank you.
Well, it wasn't a question. I just had a comment, sorry, to piggyback onto what Dr. Richards and Dr. Solomon were saying about the cancer incidence. And here in Cayman, I think it's also important to note that Cayman has a very different makeup than a lot of the other Caribbean islands. And so we can't just compare to the other islands in order to determine what our incidence and data is. So I think it's very important why we need to develop our own registry here.
Absolutely. Yes. Thank you. Right. I see there was a question somewhere. No? All right. Are there any other questions for the panel? Yeah. Ms. Flynn?
I just wondered whether these new modalities, treatment strategies, are applicable in pancreatic cancers. I haven't heard anything. I know our focus today is more about lung and breast, but I wondered about pancreatic, whether there was any newer treatment research in that area.
Right. Darley?
That's one of the strongest areas of research. We've gotten to the point now where somebody with a 3B pancreatic cancer can be downgraded to resectability. In other words, I don't know how familiar you guys are, but basically up to a couple of years ago, anybody who was diagnosed with pancreatic cancer, we just kind of said, okay, you've got a 6-month survival. And now we can get out to 38 months. So if we can downgrade them with these new modalities, these precision therapies, the immunotherapy, we can make it so that the surgery is an option more so than it used to be. So the tremendous strides.
And in terms of systemic therapy, we have the BRCA mutation that I was talking about for breast cancer is also found in pancreatic cancer. So if you have the BRCA mutation, then PARP inhibitors, which I mentioned, could be an option. And just to state how liquid biopsies could help, so in advanced pancreatic cancer, just last month, we did the liquid biopsy, we found a BRAF mutation. Mm-hmm. So the BRAF mutation is found in colorectal cancers more commonly, not so much in pancreatic cancer, and melanomas. But we could use a drug that targets BRAF, which we use is approved for melanoma for this patient if he fails chemotherapy or progresses. So things are looking up even for the most aggressive cancers.
And she mentioned melanoma. Some of the patients with advanced melanoma now get to a point where they have complete remission. So there's no evidence of melanoma that you can see with some of these therapies.
Right.
Sorry, Dr. Jeff. One of the topics that we were supposed to discuss a little bit, and I know Vineetha went over some of them, and I did yesterday, is also the whole aspect of colorectal cancer. Now, the colon, I don't know how long it is, how many miles? Right, and cancer can occur at any part of the colon. But as you move from right down to left, down to the anus, the treatment modality may change somewhat. And, we have the usual colon cancer, rectal cancer, anal cancer. And as we move along, as I say, even the targeted therapy for that specific part of the colon may change along the line. We would have heard recently from the last ASCO conference that there is now a experimental drug that persons who presented with advanced metastatic colon cancer, rectal cancer, that the disease in all of them, 100% went into remission, complete remission, right? But this was over a 6-month period. There's still a further to go in terms of these studies, but really piggybacking that, you know, with research, it appears that what you mentioned earlier on, that cancer is not necessarily a death sentence, and you know there is hope on the horizon for long-term survival.
Right. Unfortunately, we have time for just one more question. Okay. As I noticed, okay, I am going to say time enough for 2 questions. All right, go ahead and ask your question, and then Dr. Williams, you can ask yours.
I'll just make this quick. So yesterday, Mr. Smelly had done his presentation, and he had told us, which was very, very encouraging, that we'll be doing testing in the early stages in the next coming 6 to 8 months. That being said, and with the cancers that you've discussed today and throughout the last 3 days, with respect to Cayman, and I do know that DART and the Ministry of Health and Health Services are all committed to building that new infrastructure over by Camana Bay. With the cancers you've discussed, many, I'm not local, as you can tell, I'm white on rice, but with many local people, they have to endure the expense of going off island for treatments and things like that. What cancers are currently available to be treated on island? And in addition to these future infrastructures, could we actually have a cancer facility on island so that would also help alleviate a lot of the payments and struggles for people having to go overseas for treatment?
Good question.
Most cancers, I use the word, most cancers are treatable on island. And I use the word most cancers, the ones that we think about every day, the colon, the rectal, the anal, the pancreatic, all of those, we have all the systemic treatments available. Even if for today, this person has a rare cancer and say, oh, we have never treated this before, but fortunately, within weeks, we have access to the various drugs. What we don't have access to at this moment is radiation therapy, which for whatever cancer that needs radiation. And that's where the new complex with its new linear accelerator will likely provide that kind of service. There are others that we know that other therapies that we're not offering yet, but probably in the future, things like CAR T therapy. But with progress, I'm pretty certain that will happen. So it's mainly radiation therapy, if I think of anything else, that obviously you have to move to the facility to have it done, you know. But now we're bringing the facility closer.
And if we can add on to that, pediatric cancers. We don't treat pediatric cancers. That is an entirely different specialty in itself.
Right.
So at the moment, we don't have a pediatric oncologist, but hopefully we'll reach there eventually.
And there's a tendency for us not to treat acute leukemia because, again, it requires a kind of a very, very aggressive backup support, which we don't really have enough of that on island.
Right. Thank you very much. If I just want to, if I could just say one thing. So what this has highlighted is the fact that we're moving towards a time when we will hopefully soon be able to manage all of our cancers here on island. We've come a long way over the past several years, and we're almost there. We're just this close. However, there are still some cancers that unfortunately we have to send off. And, but soon and very soon, with the collaboration that's happening, you'll probably be able to have less people going off. The last question is from and anesthetist Dr. Williams.
Let me thank the panel for exciting news about the treatment of cancer. I have a question pertaining to the whole focus of the conference, which is your health promotion, prevention, and positive intervention, where cancer is concerned. I'm hoping here that we have a room full of healthy people who are cancer-free. How do we, from here, go about preventing cancer? And what research, what work is out there to promote that?
I can start off with that one in terms of, and I want to link it to the very first presentation on Friday.
Yes, absolutely.
Thursday night.
Thursday night. Thursday night.
Thursday night, as well as Dr. Ravi's presentation yesterday morning. And it's about healthy lifestyle. There are certain things that we can do in terms of, like I plan to stop smoking tomorrow morning, all right? The amount of alcohol I take, the types of food that I consume. And I'm not saying that any direct one food or the other may be direct causes of cancer, but healthy lifestyle, exercise, diet, all of these are implicated, not only in cancer, but also how do we maintain our blood pressure stable, how do we maintain our diabetes at an acceptable level. So all of these, I think, are things that we can, that are preventive. The other aspect of it is, what are we doing, or what should we do in terms of early diagnosis, right? That is very, very important. And we have a number of radiological studies that can be done. We have scopes that can be done, but we also we can do stool sampling to look for bleeding from the bowel. This may be an early hint that somebody is having some kind of colorectal cancer, for example. So these things are important. I know that my friend Dr. Martinez will every time she'll say, oh, well, this person has been smoking for a number of years. This person is at this age, so we probably should do a CT to see what is happening there in the chest, right? So there are certain things that can be done. The other aspect is, if we are fortunate or unfortunate to know that there are some kind of genomic familial thing going on, then it's important along that line that there be closer scrutiny. So instead of starting to do your scopes in the high 40s, then we might want to bring it down to about 40 years old, or even earlier, depending on what the family history is like. And the same in terms of people with family history of prostate cancer and so on along the line.
And beyond all this, if I may add, whatever Dr. Richard said, if you want to have any specific intervention to target the population, then we should know the demographics of cancer. So we come back to the need for a hospital-based registry and for more data, and I think that's where we should be, going first.
All right. Well, thank you very much. Thanks to the audience for being so engaging. Just join me in giving a big thank you to the panelists. Thank you very much.
Thank you, Dr. Jefferson and the panel. That was a very important discussion as we come to a climax of this 13th Annual Healthcare Conference. But before we wrap up, I invite the Honorable Sabrina Turner, Minister for Health and Wellness, to deliver closing remarks.
Good afternoon.
Good afternoon, Minister.
And I'm not even going to ask for a rowdier afternoon, because I guess you're feeling almost like me, acknowledging that the 13th Annual Cayman Islands Health Conference has come to its close. So I totally feel it. I trust that it has been an informative few days for everyone who has participated, whether as a speaker, as an attendee. And I can confirm, and for those of you who stuck with us, I'm happy to say that I sat for all of the sessions. And from all accounts and all the engagements that I have had, they were very insightful. People share the same sentiments, and definitely very thought-provoking. Now, as a former member of the nursing profession, the ministry, and the Ministry for Health now, I am concerned about the prevalence of non-communicable diseases in our community and the impact it has had on the quality of life for our people and the strain that it has placed on our healthcare systems. However, I am excited about the future of health and public health. And in the Cayman Islands, that is something we all should be proud of. Being excited and looking forward of what's to come. And I believe that the presentations that were shared here with us over the past 3 days can be used to inform the initiatives that are already in the works in the ministry as we shift our focus to public health and putting the spotlight on non-communicable diseases. As we leave here today, I'm committed more than ever to ensuring an equitable, sustainable, and successful healthcare system. For all, this is one of the 10 strategic broad outcomes that the PACT government has developed as part of our 2022 to 2024 strategic policy statement. There is absolutely no reason why the Cayman Islands cannot be a center of excellence for the region and even further afield. However, we must all play our part and make that a reality, and I expect each and every one of us to play and take on that role. We must prioritize the education, employment, and retention of our Caymanian healthcare professionals. And for those Caymanians working overseas, we must provide incentives for them to come home and work in our hospitals, clinics, schools, and also be able to share the benefits of their experiences. Furthermore, succession plans must be put in place and clear pathways for career advancements established to which future generations of Caymanian doctors and healthcare professionals can aspire. Looking forward, I plan to redirect funding so that more monies are invested in care, prevention, diagnosis, mitigation, cure, treatment, and as opposed to non-clinical investments, we're definitely gonna get the balance right. We need to get back on track and make preventative care and public health our national priority. Now, equitable access to quality health care is a basic human right. We need to stop talking about funding health care and have more discourse about fixing our health systems. I need to repeat that. We need to stop talking and we gotta start fixing our healthcare systems. I plan to start those conversations, and I'm so grateful that our community has been blessed to have the resources such as conferences just like this and the expertise of a diverse medical society that are ready and willing to engage in those discussions. Let me take this opportunity to thank our sponsors, our exhibitors, for their support, and once again helping us to make this conference a huge success. I would also like to take the opportunity to recognize our local and international speakers for so graciously giving up their time to educate us, each of their own unique perspectives. Mr. Ben Mead, thank you again for being our Master of Ceremony 2 consecutive years. We appreciate your commitment. The management and staff here of the Ritz-Carlton, again, only the Ritz-Carlton can do it just like this. And the GIS staff, Radio Cayman, have seen you. Thank you for being our vessels, our vehicle for getting and sharing our message. Now, if you've missed out on any of these sessions, I would like to, or you would like to hear them again, they will be available for viewing on CIG TV, YouTube channel late next week. I encourage you to share what you have learned here over the last 3 days with your friends, your families, neighbors, and definitely co-workers. The Ministry of Health is already looking ahead to next year's event, and I encourage you all to share your feedback and ideas in the survey that will be sent out next week. This will assist us in shaping the theme and format, including other suggestions for next year's event. I'm looking forward to seeing you and hearing from you again in 2023, God's willing. Thank you, and enjoy the rest of your weekend.
Thank you very much, Minister Turner. I don't think I could end on a higher note than that, so I will thank you all for coming and wish you a pleasant weekend. Thank you very much.